Rana sir updated.
You will be speaking about the introduction, no?
I will do the faculty introduction.
No, introduction about the quality.
Introduction about the course.
That Dr. Srinath is doing, no?
No, you go ahead.
You can do it as a part of your welcome speech, Dr. Srinath. I sent you the.
Yeah.
You can do that. Then I will introduce the faculty.
Okay.
Rana sir is joining by 3:30 is what he has messaged me.
Okay.
And Lallu ma'am is the one who's doing the first talk. But ma'am is also in another conference. So in case if she's not able to do the first one, perhaps can we substitute the first talk with yours?
Mine.
Yeah.
No, you do it off.
No, mine is a quality indicator topic. So it will be better if I do it later. Or other option is we can perhaps run one of the recorded lectures.
We will run one of the recorded lectures.
Kim Hansen's is a good one to start with, the IFM framework.
Okay. Ready, Kim.
When are we running Kahoot?
That will be the last session.
Okay. It's exactly or 3. Okay.
Srinath sir, it's live on YouTube. I shared you the link.
Okay.
Thank you. Shall we start? Sarona, can we start?
Just give 1 minute. Let me quickly check with Dr. Lallu. Dr. Srinath, do we have Kim Hansen's talk ready to be played? Just in case.
Ready.
Dr. Srinath, I think we can start in a couple of minutes.
Okay. Good afternoon, all. We'll be starting the quality online program in another couple of minutes. Like to wish to welcome all the delegates who are there. Another couple of minutes, we'll be starting.
Dr. Srinath, we can get it going.
Yeah. Good afternoon, all. It's a proud moment for Society for Emergency Medicine India. In the Yashoda Hospitals is live telecasting this particular workshop, online workshop on quality. Yashoda Hospitals, I would, at the outset, I would like to thank the management of the Yashoda Hospitals for being always partnering and giving me an opportunity to speak in the August gathering, and also taking forward to all the residents, consultants, quality people across the world. Yashoda always believes in the academic programs, and they are continuously helping in such programs. And the Society for Emergency Medicine India is conducting the 24th annual conference in Trivandrum on 25th, 26th, and 27th, with a theme of resilience, research, and revolution, RRR, which has become the word of the mouth for this year across the country and across the globe. So research is the most important thing for all the residents across the world, because without it, we don't know what we're going to do. And COVID and post-COVID has learned us a lot of lessons, which we have been learning. And then the society's motto is to three things always. One is service, academics, and research. So going ahead with this, we have organized this pre-conference workshop as an online workshop so that it could benefit thousands of youngsters across the world. And what is the motto today? Today, we are doing this to sensitize all the emergency departments in India on why quality of inpatient safety is very, very important, and it is an integral part of the department. And IFM is also telling about overcrowding. It's very important. When you know all these quality indicators, quality quest today, you will understand why quality is important. And the key performance indicators, which will be spoken by Dr. Saran Kumar, is another important topic which you have to know. The interaction and learning from the quality experts is the most need of the hour, especially the Society for Emergency Medicine India, International Federation of Emergency Medicine, the Consortium of Accredited Hospitals Organization, that is the CAHO, and the Quality Association Accreditation Institute, led by Dr. B.K. Rana, will be improving in understanding our ED work environment, and also the care, to give the better care to the patients who come in to the emergency department. I always say three things: a right patient to the right hospital for the right care will always have the best results to reduce the morbidity and also to reduce the mortality. To practice the golden hour, you have to know what is golden hour. When you practice in time, you're going to save the patients in time. So what are you getting on today's plate? We have the eminent speakers who are going to speak. We will be introduced by Dr. Sarvana Kumar, and later on we'll have an important Kahoot, that is a quiz, so that we can understand how much we have been told and what you have learned from. So these are all there on today's plate. Thank you, and over to Dr. Sarvana Kumar.
Thank you very much, Dr. Srinath, and I welcome all of you once again to this wonderful program for today. For the next 3 hours, we got a very engaging quality program, and you got some fantastic speakers with us today. It's my pleasure to introduce our speakers of today. So let me start from Dr. Lallu Joseph. So many of you may already know her from her CAHO circles, but she is the quality manager and associate general superintendent of Christian Medical College, Vellore, and currently she is the secretary general for Consortium of Accredited Healthcare Organizations India. Somebody who's been instrumental in propagating the quality aspects and also teaching many of us in quality. So she'll be talking about leadership and quality today. You have Dr. B.K. Rana. Many of you know him from his NABH days as the former CEO of NABH. Currently, he is the chairman of Quality Accreditation Institute, and as many of you know, SEMI has partnered with Quality Accreditation Institute to get emergency department standards for accreditation, and currently 4 institutions are accredited, and he's going to be talking about why accreditation is important. We have a couple of recorded lectures from international faculty today, as because of the timing issues, they were not able to join us live. One is Dr. Kim Hansen. Dr. Kim was the founder of the Quality Special Interest Group of IFM, and she is the chair of the board, Emergency Medical Foundation, Queensland, and Australasian College of Emergency Medicine, and she is the director of Virtual Emergency Department and medical director of Critical Care, Redcliffe Hospital, Australia. And we have a recorded lecture from her talking about the quality framework of International Federation of Emergency Medicine. You have a talk by Dr. Bruce Lowe. Bruce is the chief of Emergency Medicine Department at Santara Hospitals, Norfolk, USA, and is also the medical director of the same center. And he is going to be talking to us on some of the myths and also the pitfalls in setting up quality indicators. And that will be a recorded lecture. And we, of course, have our very own Dr. Mabel Wasnak. Many of you know her, and one of the very well recognized leader of emergency medicine. Ma'am is currently the head of emergency department at Manipal Hospitals, Bangalore. She'll be taking us through how to audit or how do you perform an audit in an emergency department. And she was also the past president of SEMI, as many of you may know. And then, of course, you have none other than Dr. Srinath, whom I don't think needs any introduction. And in case if any of you here doesn't know him, perhaps you might be in the wrong login ID or a different meeting, please check your login IDs once, right? So Dr. Srinath, of course, a good friend, colleague, and the group emergency medicine director of Yashoda Hospitals. And you will have a talk by myself, Dr. Saravana Kumar, the National Secretary for Society for Emergency Medicine India, and the unit director, Dr. Mehta Hospital, Chennai, I'll be taking you guys through the quality indicators which are relevant for the Indian context. And that's not at the end of today's sessions. We're going to have a very interesting online Kahoot quiz, which all of you will be able to play live online. And please stay tuned to that session. It's going to be a very interesting online experiment, right? So with that introduction, I think we will get it started. We're going to be having slight change in the order of presentations. The first one is going to be a recorded session by Dr. Kim Hansen from Australia, and that will be followed by Dr. Rana's session. Dr. Srinath, can we play the first session, please?
Hello, my name's Kim Hansen. I'm an emergency physician from Brisbane, Australia, and I'm delighted to speak to EMCON 2022 Quality Workshop. Thank you so much, Semi, for inviting me, and in particular, Dr. Saravana Kumar. I'll be speaking on an updated framework on quality and safety in emergency medicine. It's customary here to acknowledge the traditional owners. So for me, that's the Meanjin people here in Brisbane, Australia. I'm speaking on an updated framework on quality and safety in emergency medicine. This was published in the EMJ in 2019, and this is the updated version. The initial one was published in 2012. The QR code will take you to the site. We face similar challenges across the globe in ED at the moment. Emergency departments are increasingly utilised by patients, presentations often outstripping population growth. We aim to offer accessible, timely and high quality urgent care, but sometimes because of the volume we can't. We function as a safety net function, giving healthcare to the most vulnerable people in our communities. We know the use exceeds population growth, and even in ageing countries such as my own, Australia, the use exceeds the rate at which the population is getting older. And the systemic challenges everywhere of crowding, assessment and treatment delays. So what are the enablers and barriers to quality care? These are similar wherever you practice emergency medicine. Enablers, staff, and barriers, lack of staffing numbers. Enablers such as the physical structure, the buildings which we work in, and the equipment that we have. Emergency department processes, both smooth and efficient, and some of them clunky and bureaucratic. Co-located emergency care and what we're able to offer with the hospital that we work with. And the monitoring of outcomes. How do we know we're doing a good job? Is it just the number of people we see, or is there more to it than that? We focus on these four things. Expertise in critical care. These are the people that need us the most. It's life and death, and that's what we're trained to do. But we also offer access to specialist services in a rapid manner, which often isn't available through any other channel. We can offer additional services at the hospital where you might not, such as simple procedures that are not on offer anywhere else in the community. And the duration is appropriate. We have a queue and we have to keep moving forward. Avidas Donobaden was called the father of quality, and he had this quote: ultimately, the secret of quality is love. If you have love, you can then work backward to monitor and improve the system. What he's talking about is a passion for our work, for our patients. If you have that, and I know you all do, because you wouldn't be here otherwise, then we can work out what we need to do to give them great emergency health care and how we measure that. So let's talk about ED crowding or overcrowding. There is potential for a reduction in both the quality and safety of care, especially if capacity cannot grow to match demand. That's written in the updated quality framework, and it's never been truer since the pandemic. when most emergency departments around the globe are simply overrun with patients. There is a need that on many days cannot be met. This is what it looks like in different corners of the globe. The one in the top right is the hospital where I started my emergency medicine training, Gold Coast Hospital in Australia. You may recognise some of the others. Crowding is inconsistently defined and measured, but ideally should comprise of a combination of both non-flow items, such as ED occupancy, and flow items, such as length of stay. You need both. You need both flow and an adequate capacity, number of spaces, to avoid overcrowding. This is the best diagram that I've found to depict what crowding looks like. In an uncrowded hospital, there is capacity both in the emergency room and on the medical and surgical wards. And so patients are able to enter an empty bed in the ER or ED and then move to the appropriate inpatient space. In an overcrowded hospital, we have patients, such as the red ones, that are in corridors, they're boarders or inpatients, they're unable to move to the appropriate ward. And we also have outliers represented in yellow on the surgical ward. And we know outliers have an increased length of stay and a decreased quality, and we want to avoid that. IFM has sponsored a number of good works, including the updated quality framework, but another one is the Emergency Department Crowding and Access Block Task Force. This group formed in 2019 and created a white paper, a 9,000-word document on crowding, and it's worth a read if you can. I'll put the QR code up later. Key aspects in maintaining quality in EDs. So what can you do? From IHIs, whatever you're aiming to improve, definitely do the plan, do, study, act cycle, and cycle it again and again and again. What are you trying to accomplish? How will you know that a change is an improvement? And what change can we make that will result in an improvement? This is how we improve the services for our patients, ever evolving. Having guidelines. It's really important that your staff have access to guidelines, they know how to get them rapidly, they're familiar with them, and that those guidelines are usable and implementable. This is an example of ACIP's guidelines, which are freely available on any web search. For paediatric, you can't go past Royal Children's Hospital in Australia, which has fantastic guidelines for almost every paediatric condition, as well as patient handouts or carer handouts. Audits. It almost doesn't matter what you audit, but you do need to do some audit to ensure that the care you provide is what you aim to provide. One thing you can do is audit compliance with a guideline. Incident monitoring. In Australia, we've set up the Emergency Medicine Events Register. It's an online portal where staff and patients can anonymously enter an incident, an adverse event, a near miss, or even a good save. We collect these and analyse the themes behind them and then feed that information back to the emergency medicine community via ASIM channels. Is there something similar at your hospital, in your network, or in your country? Morbidity and mortality. These are really an established part of most EDs, and it's an important chance for us to gather and review the care. It's got to be done the right way though, in a no-blame manner, where clinicians feel safe and able to be vulnerable about the care, the decisions they made at the time and why they made them. Because we know everybody's working hard, they're well trained and they're trying to do their best for every patient, but sometimes it just doesn't work out. So it's important to identify those system factors so improvements can be made for the next patients. And integration. EDs don't operate in a vacuum. We're one of the most integrated parts of the healthcare system, pre-hospital, hospital, and post-hospital. And it's important that all those interfaces are smooth. So what about quality indicators? These are the different domains which we put them under: safe, effective, patient-centered, timely, efficient, and equitable. And I've listed here, and they're in the paper as well, a number of different quality indicators that you can use in your department to ensure that your patients are being provided safe and high quality care. We've listed them under 3 different items: structure, process, and outcome. Don't need to do them all by any stretch of the imagination, but pick some, audit them, and report on them. So things like ambulance notification system, time for patients to be investigated and treatment, appropriate use of investigations, and in terms of equitable, the patients have comparable outcomes despite their gender, race, or religion, for example. Here's a couple of documents that you might find useful. It's quality standards for emergency departments, hospital-based emergency care services. It's a comprehensive document put together by ASIM. And of course, the other one is our updated framework on quality and safety in emergency medicine. It's available both on the IFM website and also published in the EMJ. The EMJ has a shorter version, but you can use either. Thanks so much for your attention. I would like to thank IFM's Quality and Safety Special Interest Group. This work wouldn't be possible without a number of members, and you'll recognise some familiar faces there. I'm very happy to be contacted by anyone. This is one of my favourite topics, and I'm always happy to meet new people and discuss these issues with you. Thank you so much. Enjoy the rest of your workshop.
Thank you. And of course, in the first talk of today, Dr. Kim has set the context very clearly. And there are 3 core points which I would like to reiterate from her presentation today. One, she gave us a bit of resources which we can refer to for our emergency departments. And I would recommend everybody to go through the IFM website, the resource section, and also the quality special interest group section, where you will find a lot of useful resources for you to adapt. She also spoke about the usefulness of clinical audit in the emergency department, and you're going to be hearing about it much in detail from Dr. Mabel, who's going to be talking about that today. And the third important thing which she spoke about is the scope of quality indicators and how do you measure the structured process and outcomes. And that's a very important topic of discussion for today as well. I think we will move on to the next talk for today. And Dr. Srinath, is it okay if I can go ahead next?
He's on a call. I think you can go ahead.
Okay. Naveen, can you kindly confirm that you are able to see my screen?
Yes.
Oh, thank you. All right. So very good afternoon once again to all. And I think we'll move on to the second session for today, which is on the essential quality indicators for emergency department specific to India. And I'm Dr. Sarana Kumar, and it's happy to be here as a part of the EMCON 2022 quality workshop. So I think these are not familiar or unfamiliar to us. Many of us here are working in predominantly a private setup and some in the public setup. But whichever setup you are in, as an emergency physician, especially as a young leader in the emergency department, these are some of the expectations which we get right from day one of our job. Basically, they expect us to provide exceptional clinical care and manage the best of clinical outcomes. There is also a certain degree of business expectations if you are in a private institution, private or public, but definitely the customer satisfaction is something which the top management wants us to focus on. You also have or thought about how do you grow yourself personally, and also how do you grow you and your team professionally, and also how to manage quality and patient safety. If you look at this list, clearly your clinical outcomes, your customer satisfaction, and your growth of the department, one of the key areas for achieving those successes is in ensuring good quality and patient safety. That will ensure that you will make your emergency departments successful. So what we typically do is we think we need to implement this quality and patient safety. So let me start looking at a quality accreditation program for my emergency department, or I will heavily be dependent on my own hospital quality department to tell us or tell you what to do in the ED in terms of quality. So in that due process, where we will end up is typically start measuring some of those quality indicators because somebody else has asked us to do so, or an accreditation body wants some of those indicators to be submitted time on time. But we need to first understand quality and what we need to deliver in our emergency departments. We're all used to this, where we start measuring things because either it is too easy to measure, or this data is readily available and somebody else is happy to actually kind of put this data or some data in an Excel format or a PPT format and give it to us, or somebody else wants it. For example, the quality department of the hospital has asked us to submit certain quality indicators because they have to do it for some of the compliances with accreditation bodies. But think about for a second, right? That's not how you look at quality, or you should practice quality, right? Don't measure something because we can measure it, because the data is readily available, or because someone else wanted us to do so. So then what to measure? Measure things which will help you improve your department, which will help you move towards better patient care, better customer satisfaction, better clinical outcomes, right? But for you to move towards that and for you to measure that, first you need to understand where do you currently stand with regards to these three aspects broadly, in terms of clinical outcomes, in terms of your customer satisfaction, and also in terms of your processes and policies, right? So broadly speaking. So first, understand your department on what you want to improve before you set out quality indicators for your department. Please don't take a list of prescriptive quality indicators which are either available when you Google, or it's available either as a ready reckoner from some other healthcare system, or maybe an accreditation body has asked you to do so, right? So then what do I set as a quality indicator, or how do I set as a quality indicator? How do I set a quality indicator? So this is where you need to put some thinking into it, right? When you want to improve certain outcomes, always you should measure the process component of it and also the structure component of the same. Let me give you an example. If you want to improve, say, urinary tract infection or catheter-related urinary tract infections of your emergency department, right? Those who underwent catheterization in your ED, you don't want them to have urinary tract infection. So if that's the outcome which you are setting out to measure, what you need to measure is clearly the process. Here the process is how are my postgraduates or residents or consultants or even myself are performing at the procedure of catheterization. Is all the aseptic techniques and precautions followed? Is everybody washing their hands? So you can measure hand wash complaints, adherence to the steps of catheterization. Right? These were some of those process measurements. But what is a structured measurement? You need to think, am I providing them adequate hand wash opportunities or hand wash stations? Is there a hand rub available right next to the patient's bed? Have I provided them an adequate space to do a certain procedure, right? This is just as an example. So if you want to increase or improve an outcome of a certain condition, always start measuring the process related to that outcome and also the structure related to that outcome. Most common mistake which we do when we set out quality indicators for emergency departments is clearly you measure a clinical outcome of a certain nature. For example, the outcome of cardiac arrest patients in my emergency department, okay? But what are you measuring, or what are you trying to improve? What are the process measure for the same? Oh, process measure, we are actually Also looking at what is the time taken for somebody to go from ED to the CT room in case of a stroke. And in terms of structure, I'm measuring how many patients or how many patient beds I need per shift as an example, right? So if you look at it, none of these have got any correlation with each other. So you are not going to improve neither your performance on stroke nor your outcomes on the one which you wanted to set up, right? So please remember, any quality indicator you set, any outcome you want to improve, look at what is the process component of that outcome and what is the structure component of that outcome, and start measuring those. And unless you improve those structures and processes, you will not reach a desired outcome. All right. So we spoke enough about structures and processes. Let's talk a little bit about our emergency department itself and an ED flow. I think most of us are very familiar with this, but let's quickly recap on how an ED flow looks like in an Indian context. So clearly, you have an input process, basically how a patient comes to your emergency department. You got a throughput process where what happens to the patient in an emergency department. And we have an output process, which is basically your disposition or the end result of your throughput. So look at the input. Clearly, you know, how do patients come to our emergency departments? You have patients coming in through ambulance. And in our Indian context, you have most of the patients, especially the sick ones and priority ones, actually coming by their own vehicles or auto rickshaws or whatever, right? The second one is you get patients who refer from another system or another hospital coming in, or your own specialist refer those patients, or patients simply walk in, right? And there is an opportunity, or there's always a possibility, not opportunity, always a possibility of a mass casualty incident, right? And some of those patients are direct walk into a particular consultant. Fairly, these are the 6 or 7 ways any patient would come into our emergency department, right? Direct or through referral or through an ambulance system or through their external vehicle service provider, broadly speaking, right? Once they come into the emergency department, what do? Clearly, everybody gets some sort of a triage. Could be a nurse, could be a doctor. Definitely, there is an initial assessment and an immediate treatment for those cases who need acute resuscitation. For those who don't need an acute resuscitation, priority 2 and 3 patients, clearly there is an history-taking examination, further monitoring, specific investigations. And in the due process, you also stabilize the patient, treat, try to come to a diagnosis, and then you manage or you plan what is the future sort of management or a future disposition of this particular patient. And the last one is clearly, once you have decided, either you're going to admit the patient, or you're going to refer this patient to an OPD saying you don't need an emergency care, or you're going to refer this patient to a particular specialist because he has got a very specific issue, right? Or you're going to move him to a different hospital, either it could be government or it could be a private center, transfer to a different entity. Sometimes these patients might say, I don't want to continue treatment here, I want to leave. So that could be a Dharma, Lama, left without being seen, all those. And some you might treat and discharge, and some unfortunately will have mortality in the ER. I think broadly we all understand this, and this is what we do day in and day out. But look at these steps little closely. Even broadly, you got closer to about 7 or 8 input parameters. You got about 8 to 9 throughput parameters, and again, a 7 or 8 or at least 10 output parameters happening within your emergency department. You got huge areas of issues in some of those specific areas. You got huge opportunity to improve some of those issues which we see in those specific areas. And we all know there are this lot of issues which we see in many of those areas, right? Let me quickly take you through some of those slides on what you can measure across these areas. Typically, we know what we measure today is some of those broad areas like door to triage, or you measure return to emergency department within certain times, right? These were some of those broad areas of measurement, but look at these things carefully. So let's look at the input process alone, right? And only take the ambulance process as an example, right? I don't want to be prescriptive here, but I'm just giving you some ideas and thought process on how or what you can set out to improve if that particular point is of interest or is a problematic area in your institution, right? Very clearly, we all know that like we do miss multiple ambulance calls or EMS calls. Sometimes nobody is there to pick up the phone calls, or sometimes if they pick up, it's not the right person who has answered that phone calls, or sometimes we have not noted down the correct condition of the patient, and we end up dispatching a wrong ambulance. In other terms, a BLS ambulance instead of an ACLS ambulance. Very common scenario in many of our ERs, right? But these are some of those areas where you got huge scope for improvement by measuring how many calls you missed. Did we dispatch? That means this is my teletriage process efficient? Is my discharge turnaround time correct? And did I miss any critical pickups? Because these are some of the things which is going to help customers or patients develop trust on our emergency department when you call our department, right? But we don't think about those things. We only talk about more an ambulance turnaround time from the time of dispatch to patient coming back to ED, or maybe from the door to the bed, or maybe bed to the CT, right? But look at it in a broader perspective, right? When somebody is in need calls your emergency department and none of your colleagues pick up the phone or to dispatch an ambulance, or they dispatch a wrong ambulance without a paramedic, it is clearly going to affect the clinical outcome of the patients who are coming in. Right. So these were some of the areas we can look at. Other areas like equipment failures, breakdown during transfers, these are some of those areas you can consider. And one important point which I want to reiterate here is opportunities where you can treat some of those patients during en route, but we have missed to treat. Very simple conditions like, say, even hypoglycemia, many a times we see our ambulance is dispatched by bring the patient, they bring the patient back to the ER, but the patient is still hypoglycemic. And it's actually quite interesting where many a times the paramedic who was accompanied or the nurse who was accompanied has actually measured glucose levels and clearly knows this is a case of hypoglycemia, but unfortunately failed to initiate any sort of treatment. These were some of those areas where we can look at what were the opportunities we missed to treat a patient during transfer, right? Any preventable deaths, ambulance ED times. Think in those terms if you think you need to set up a strong EMS system in your department and you think there is a problem area and scope to improve that, right? The second area is how does patients come in, right? Your waiting time, your door to triage nurses, which are pretty standard and most of you know. I don't want to reiterate those points, right? So left without being seen and things. So these are some of those areas on how when somebody walks into the ER, how many of them are being turned down or how many of them actually leave the emergency department without being seen, right? And the third thing is to clearly measure how many number of PD or your priority one patients actually come through non-ambulance services, hospital arrival to the, and even if they land at the hospital, many a times when it's our own ambulance who brings the patient, many of us know and kind of receive those patients from the gate to the ED department. But the problem arises when these sick patients are either brought by an outside ambulance or by an outside vehicle like an auto rickshaw or car or something. We don't even know there is a patient who is in our gate waiting for a stretcher or a wheelchair to be moved into the emergency department because we haven't heard any ambulance sirens, right? These were some of those areas to see how many priority one patients have come in non-ambulance services of your hospital and what was the actual time taken to shift them from, say, the entry to the hospital to your ED bed actually, right? These were clearly some of those areas of improvement, right? Many of those patients end up moved to an OPD area because nobody realized or recognized that this is a priority one patient who needs emergency care and they need to go to ER, not wait in the OPD. Those are the ones you need to measure to see, is there a process improvement here on how do I set up an alarm system if a vehicle comes in to alert an ER? How do I ensure that I move these patients to the ED, not to the OPD areas? These are some of those processes you can set right so that the clinical outcome at the end of the day and also the customer satisfaction both is improved. Inside the ED, pretty straightforward. We all know it's all process dependent management most of the time. So clearly you got a lot of process times which you can measure right from your triage time, door to doctor, door to nurse, needle time, your investigation time, all your diagnostics, including your POCT, your pain assessment and reassessment area. One of the most commonly neglected zone in many of our EDs, where at least 60 to 65% of us do some sort of a pain assessment based on the study, but hardly about 20% of us do reassessment of the pain in the EDs, right? So these are some of those scope areas which we can definitely improve. And think in those areas are new terms on what we can improve, right? And clearly customer satisfaction and centricity in terms of are we providing adequate comfort, communication, compliance to treatment protocols, clinical outcomes in terms of certain resuscitation, lysis goals, goal times, all those things, right? I mean, you might also measure some of those compliance rates in terms of procedures, in terms of hand wash and all those things within the ED, right? Don't just limit yourself to picking 2 or 3 easy ones, which is my mortality in ER, outcome of CPR, outcome of stroke thrombolysis, door to CT time in stroke, door to a cath lab time in cardiac. So these are the 5 common indicators I start measuring. Don't do that, right? Look at your specific ED and see what you can improve in your ED, right? And finally, at disposition, right? Clearly, you got a huge scope of improvement. We all know many times we wait for beds in the ICU or in the ward, and because of this, these patients end up waiting in the ER for longer than usual times. Those are some of those areas to look at. How do I improve this process, right? How do I get into an alternate area for these patients so that my new acute patients who are coming in get adequate care and time? I don't want to share my resources too much with somebody who's waiting to get onboarded, right? And also some of those administrative aspects, like for example, missed bills in the emergency department, number of correct bills, right? Complaints to your documentation, which has got significant legal implications in the current times. These are some of those things you can actually audit or also measure, right? And the interesting part is none of us actually measure the efficiency of our teams, right? We only think outcomes only mean the customer outcomes or the patient outcomes. But what about the efficiency of our teams? If you are running an academic program, you can actually measure how is their training paying out in terms of outcomes, in terms of their performance, in terms of their publications, in terms of their examination marks, right? In many of those aspects, right? And clearly other administrative ones, which are quite straightforward, like volumes, revenues, and cost, and all those. I'm not going to explain those to you, right? But look at areas on where you can improve on what sort of an emergency department you have, right? And set a quality indicator. And again, I reiterating the same. Don't get into this mode of I pick 3 or 4 easy ones because that's where I get data quite easily, or that's what somebody else like a quality department asked me to do. Don't get into that mode. Look at the specifics of your department, understand what you want to improve in your ED, what is your specific problem with the healthcare system which you are working in, and try to set up an outcome measure and measure the process and the structure for the same. So in quick summary, understand what's your unique problem, try to set out your quality indicator to measure, to improve that particular problem. Feel free to use quality tools. Today, there are plenty of quality tools available, right from your Pareto, right from your Fishbones, right? It's quite easy to learn, right? You don't have to do a complicated workshops to understand all this. Simple YouTube videos can help us how to use such efficient tools. Please learn to adapt those tools. Always measure the process and also the structure for you to improve those outcomes, right? You need to measure all 3, the outcomes, process, and structure related to the same parameter. And you don't need to set objective outcome measures for everything. Even a subjective measure of to see what do you think is the overall compliance rate of your team in terms of communications. It's very hard to measure objectively, but you know by a random survey, or you can perceive that the communication level of your department is actually good or reasonably okay or bad based on the overall customer complaints and feedbacks you hear from patients, you hear from other departments, and from your colleagues, right? Sometimes the subjective measures are also good enough as an outcome measure. You need not always think about an objective number-based measure, right? And try to set a benchmark and try to beat it. So it's hard to get international benchmarks or even Indian benchmarks for some of those process measurements which you are doing, right? And not all the systems or hospitals are standardized in that area. So you cannot really say this is a real benchmark. There are certain benchmarks, clinical benchmarks we know. For example, your door to balloon time or a door to needle time. But for many of those, you don't have a benchmark, right? So the best thing to do is to try to set your own benchmark or your own best value and try to beat that in the next cycle, right? And also, accreditation does help in this regard because now there is a third party which is monitoring and supervising this. So eventually they will push you to do better and push you to perform better. So accreditation definitely helps in my opinion. And in fact, we have an entire session coming on next by Dr. Rana on the ED quality accreditation. So I'm not going to be talking about that. But if I have to give you one take-home message from this, don't measure for the sake of measuring it. Find what is your problem, measure something so that you can improve on that particular problem. I think with that, let me stop sharing and thank you all for the patient listening. So Dr. Naveen?
Yeah.
I think both Dr. Rana and Dr. Lalu are going to be slightly late. So I would actually suggest, shall we play Dr. Bruce Lowe's recorded lecture, please?
Sure.
Thank you.
Hi, my name is Bruce Lowe, and we're going to talk about building your QA program. So first off, you become the new ED Quality Director. Congratulations. Then administration comes up to you and says, hey, we've been looking at the sepsis mortality and it's not very good. What are you going to do about it in the emergency department to help fix this? A couple of years later, you do a good job. You get promoted to chair. Congratulations. Then you find out you have some issues with some of your partners. You have one physician who discharged a patient and comes back in cardiac arrest 2 days later. You have another physician who had several unrecognized esophageal intubations. Administration comes back to you and says, hey, I think we have a problem. How are you going to fix this? So a little bit of background. Errors, unfortunately, are fairly common in the emergency department. If you look in the literature, it's thought that about 10% of all patients in the emergency department suffers from some sort of error. Now, the good news is the majority of those errors don't cause patient harms. The bad news is the majority of those errors are actually preventable. Unfortunately, the culture is set that there's not a lot of incentive to report when somebody makes a mistake. If you think about it, if you make a mistake, you give a wrong dosage of medications or gave the wrong medication to the wrong patients, and you report that, what typically happens is you undergo some sort of disciplinary action yourself, as opposed to, hey, what happened? What can we do to make things better? So why do QA? Well, the first question we want to know is, how are we doing? You don't know unless you ask the question and look to find out. The second thing is about mitigating risk. If you work in the United States, for instance, very litigious in terms of medical legal actions when patients have bad outcomes, and so having a solid QA program can help mitigate some of those risks. And lastly, and probably more importantly, it's about improving patient outcomes, right? We want to make sure that if there are issues, what can we do to prevent bad issues from happening, especially bad outcomes for patients? It's about patient safety. And lastly, it's also about reducing clinical variation, right? So why is it that you may have one physician that orders more CT scans compared to another, and yet their outcomes are the same, right? What can we do to reduce clinical variation and make it safe for everybody? All right, there are several types of errors we need to talk about. The first is called a no-fault error. Essentially what that means is bad things happen and it's nobody's fault, right? Sometimes you can't predict when people are going to have bad outcomes. And if you look prospectively what happened, there really wasn't anything in terms of opportunities to make things better or prevent their outcome. Next are system errors. And what that really means is that there are issues outside the control of the individual physician or frontline staff that may them lead to the error or problem. And lastly, there are cognitive errors. Now, these are individual that goes down to, and they're really broken down to two different kinds. There's knowledge-based deficits and errors in decision-making process. So how do we define quality? Well, it's a difficult one to answer. And if you ask 10 different people, you'll get 10 different answers. I also think of it as one of the U.S. Supreme Court justices when he was asked to define how do you define hardcore pornography, and he said, I know it when I see it. And I think historically, quality has been somewhat of a similar approach where you can kind of know it when you see it, but it's really hard to put into words. What does it actually mean? When we start off with this quality journey, there's three questions that we like to ask. The first is, what should we measure? Second is, how do we measure it? And lastly, and probably more importantly, is when we get this information, what do we do with it? So first off, what should we measure? Well, if you think about it, there's really two kind of buckets. One is measurements that are patient-centric versus those that are surrogate. Now, if you do research, you know that ideally we have some sort of patient-centric outcome, such as mortality or reduced disability. However, we know that oftentimes those are fairly lofty goals. They are often require multiple different stakeholders, multiple variables, and they're hard to kind of measure in effect to a singular change. Oftentimes what we end up doing is measuring surrogate markers. For instance, we know that having long wait times in the emergency department leads to worse patient outcomes. So a lot of times we do surrogate markers, right? So what's our length of stay for patients, right? How quickly can we see the patient from the arrival to the emergency department to when they can be seen by a provider? We can also look to guidelines, whether they're national government benchmarks or registries or medical society recommendations. For instance, we know that aspirin is good for giving people who are having heart attacks. Those are all the guidelines, and so those are probably a quality measure. We know it's relatively safe to say that this is something that we should be doing, and we should be measuring it. And then ideally, you want to be specific to the emergency department. Start small, make it ED-centric. If you think about sepsis, for instance, ideally we want to be able to do interventions or quality measures to help reduce sepsis mortality. But we know that when people get admitted to the hospital with sepsis, especially with septic shock, it's not just us in the emergency department, but it's also what happens as an inpatient in the ICU, the nursing care. And so there's all those other things that affect us. So that may, in of itself, may not be a great ED measure from a quality perspective. Then how do we measure it? Typically, it's retrospective, right? Sometimes something triggers it, a bad outcome or a patient complaint, and that usually triggers some sort of quality review. Ideally, you will be able to do prospective evaluation. You will take a measure, see how we're doing it, regardless of patient outcome, to see if we're doing what we're intending to, that we wanted to do. And then once you have figured out kind of what you're going to measure, you're going to figure out how you're going to measure it. Ideally, if you have electronic medical record, it can be automated and quick and easy to get the data. Oftentimes, though, you may have to go through the TART, manually extract the data, and that requires a fair amount of effort and resources. If you don't have a lot of time or resources, you may not be able to tackle certain quality measures. You want to make sure your QA team is competent. They're trained to know how to extract data and how to interpret it. And lastly, you want to make sure you standardize the process. So whoever is extracting the data and reviewing it is doing consistently the same time every time, regardless of individual or who's doing it. And lastly, what do we do with this information? Well, ideally, you have a goal set up, what you want to do, what you want to measure, and what kind of outcome you want to achieve. You measure it, you have some sort of intervention, and then you remeasure it to see what your performance is. Going back to sepsis as an example, for instance, let's say you want to measure compliance on lactic acid on those who have sepsis, right? So you want to measure it, see how you're doing, do an intervention, go back and see if the intervention make a difference or not. Some other tips in terms of building your QA program. A lot of times it's great to get feedback from the front line in terms of what they think are issues that need to be addressed. Having a QA committee that's diversified with various stakeholders. So for instance, in your emergency department, not just having an emergency physician review cases, but you may have a nurse to review what happens on the nursing side, or you may have somebody from radiology to review issues that involve imaging and so forth. You also want to do a prospective evaluation. So a lot of times when we get a case, it's because something bad happened or some sort of adverse outcome. So we kind of know what happened. We know the punchline. But what we really want to do is take it from the perspective of the individual that's going through the case prospectively. What do they know at the time, and do they make reasonable decisions knowing the information that they had? And lastly, you want to be as transparent with this process as much as possible. If you have policies or procedures or forms, make it available to see what people know, so what the process is like. What you don't want to do is turn this into a witch hunt, or at least a perceived witch hunt. So let's give a couple examples here. So sepsis. In my institution, we have a multidisciplinary committee. Now it's involved folks in the emergency department, like physicians and nurses, but also those on the inpatient team, the admitting hospitalists, the intensivists, inpatient nursing, administration, lab, imaging, all are part of our multidisciplinary team. Pharmacy. From an ED perspective, we like to focus those are ED-centric. So early identification. Are we giving appropriate and early antibiotics? Lactic acid ordering and repeat lactic acid ordering after resuscitation, and of course, are we giving appropriate fluids? And so we can measure that as a bundle compliance, and so it's a surrogate marker. It may not affect the patient-centric outcome of mortality, which is kind of the ideal outcome, but using a surrogate marker, things that we know can improve mortality, we can see at least from an ED perspective, are we doing quality work or not? Ultrasound. A lot of times in this day and age, most people are being trained with point-of-care ultrasound, but if you've been practicing for a while, you may not have gotten training in point-of-care ultrasound during your residency. In our institution, we have specific rules about who can do point-of-care ultrasound, just because we know that if you do point-of-care ultrasound, and if you're not really sure what you're doing, you could make the wrong diagnosis and lead to patient harm. So if you don't meet those criteria, you cannot do or supervise point-of-care ultrasound. We also have specific triggers of which when we do QA or review those ultrasound cases. And then we also prospectively review about 20% of all ultrasound cases to look for quality, right? image acquisition, was it adequate or inadequate? Were the images interpreted correctly that were obtained, right? Even though there wasn't a bad outcome, we want to know ahead of time, are there things that we can do better so that we don't run into an issue where somebody misinterpreted something and leads to a bad outcome? And lastly, intubations. So we do have a very strict criteria about when we do reviews for quality for intubations. As examples, and there are things that we do for our prospective. For instance, we review all trauma intubations. And the reason is we know trauma airways are all difficult airways. We want to make sure that we're all doing it the right way and there's no opportunities for improvement. We also look at intubation procedure numbers. If we know that on a yearly basis, it's a technical skill. If you're not doing a lot of intubations, well, maybe your intubation skills may not be up to snuff. And so if you don't have enough intubations, we actually pull individuals to the sim lab to look at to see, do we think that they have adequate skill sets, or if there's concern, do they need further education? And lastly, in our institution, we do make all physicians take a difficult airway lab every 2 years. A lot of different airway equipment or backup airway equipment that exists. If you don't use it very often, you don't maintain that skill set. We also know that most intubations are fairly smooth, but the number of difficult intubations can vary that you may have experience with. And so if you haven't had a lot of difficult intubations, you may lose that skill set. So going through every 2 years, doing it for everybody, regardless of how many you've done, really helps kind of improve the quality, and we're not singling people out. Now, there is a word of caution when you do quality. Some metrics may not be that useful, and you may have some unintended consequences, right? So you may kind of influence or say, what, we want certain, for instance, length of stay to be short, and people start taking shortcuts in terms of their care and evaluation of the patients, and then you have some quality issues as a result. So be careful about what quality measure that you're doing and potential unintended consequences. So an example, 72-hour returns is a very common one that we use in the emergency department as a measure of quality. Well, it turns out it's actually a lot more complicated, right? Is it expected versus unexpected? Let's say you do an IND of an abscess and they don't have adequate follow-up, so you want them to come back to the emergency department in a couple of days for a wound check, right? Perfectly acceptable, right? Nothing wrong with that from a quality perspective. Then there may be issues of threshold admission. Let's say somebody has cellulitis. We know that we try not to admit people if we don't have to the hospital. You send them home with antibiotics, maybe they come back the next day, it's not any better. And somebody may say, oh, you know what, we'll just admit you to the hospital because you quote unquote failed outpatient therapy, whereas they really hadn't enough time to say if they actually failed or not. So in of itself may not be a good quality metric. If you look at studies that looked at this particular metric, they've actually questioned the value utility to say, is it quality or not? And lastly, think about a balanced scorecard, right? So you want to measure some things, let's say length of stay, throughput, and flow. We know patients who stay there a long time, it affects their quality as well as everybody else because of limited resources and delays in taking care of patients. But you don't want people making shortcuts, as I mentioned before, that may adverse their outcome. So looking at other things such as their stroke care, STEMI care, look at maybe 72-hour returns. In those instances, at least those with unexpected admissions to the hospital or some sort of adverse outcome may be worthwhile in that aspect. And then looking at other things too, like what was your nursing resources like? We know that since the pandemic, we've been strapped for resources, nursing in particular. And so if you have things that you're not able to meet from a quality metric standpoint, there may be a reason it's not apparent, such as not having available enough resources. So in conclusion, do develop a QA program, use it as an opportunity to improve patient care. When you go through the journey, make sure you standardize the process, make it transparent as possible so it doesn't feel like a witch hunt. And then when you do focus on or identify opportunities for improvement, focus on things that are system issues as opposed to individuals. It's a pleasure giving a talk to you. I appreciate taking the time. If you have any questions, that's my email. Feel free to reach out. Otherwise, I hope you enjoy the rest of your conference. Thank you.
Thanks, Naveen. Can you please stop the recorded one? I think that's a very interesting lecture and it's a very different perspective and perhaps a good insight into how the quality perspective is taken in the US, especially in United States. And as you can clearly see, there's a lot of emphasis on the clinical quality and clinical performance, unlike our setup where we predominantly focus on process timings and turnaround times. But the core competence of the team, the nurses, the doctors, is absolute importance. I think that's something which we can learn from developed systems to adapt in a context like India. Is Rana sir has joined? Naveen, can you see Dr. Rana?
No.
Okay. In that case, Dr. Srinath, would you mind doing your session first so that we can invite Dr. Rana?
Yeah, sure.
Oh, you can do mine, Sarvana. You want to do mine later?
Oh, ma'am, you are here. So I'm sorry. I didn't
I'm
see-
here for some time now.
Oh, okay. I think it was in a different name. So I didn't.
I'm logged in as Neil. I use his.
Okay.
Yeah.
Ma'am, then you want to do now? You're most welcome. to
No
do.
problem. But you play my recording,
Sure.
and I'm
Sure.
here only.
Okay. Okay, ma'am. Sure.
I'll start, and then you can play the recording.
Oh,
Okay.
yes, ma'am.
So it's very nice to be here. It's very nice to be here, and I'm glad all the participants here are there because they're interested in quality. So a quality workshop is something that people who are only interested in quality would actually attend, and quality is a neglected but a very, very important part of the emergency department. So Dr. Rana will talk about the ED and quality in the ED. I'll talk about an important measure of quality, which is an audit, a clinical audit. So the reason I recorded my talk is I'm always a little worried that the recording, the net won't work or something will happen. So I feel safer that it's recorded. You can play my talk, Sarvan, and I'm here only.
Thanks a lot for joining us today, ma'am. And it's a pleasure having you here. And in fact, just for the participants here, so every year henceforth from 2023 in Feb and August, we'll be having a physical program on quality, and it's a quality certification program for emergency department champions. And thanks to Mabel ma'am who has championed it, and she has now extended her support to host it in Bangalore at her institution, Manipal. Ma'am, you want to talk about it a little bit?
Yeah, so we'll have the first workshop on the 17th and 18th, or is it 18th and 19th, Sarvana?
It's 18th
It's the
and 19th.
Saturday, Sunday.
February 18th and 19th.
February 18th and 19th. It's first come, first serve for limited number of registrants. It'll be a couple of interactive sessions and a lot of tabletop exercises. So we invite all of you to come and attend the workshop. It's in Bangalore. It's at Manipal Hospital, Bangalore. So we'll start registrations through semis. So please do join us for the workshop. It'll benefit all of us immensely. Yes, Arman.
Thank you, ma'am. Naveen, can you please Naveen, can you please play the video, please?
The last few speakers have spoken about quality in an emergency department. One of the parameters to measure quality in an emergency department, a very important parameter, is clinical audits. So a lot of us are doing clinical audits, but in the next 15 minutes, we'll review how a clinical audit is done and the importance of a clinical audit. So what do you understand by a clinical audit? A clinical audit is a clinically led initiative which seeks to improve the quality and outcome of patient care. So what do I mean by that? We are all doing so many procedures in an emergency department. We have so many processes in an emergency department. Right from the time the patient enters, registers, comes to the emergency, is seen by one of us, and a treatment plan is made. So all these processes have to be audited. If we audit these processes, we will know whether what we're doing is right or if there's any improvement. And there is a systematic way of doing it. So when you do an audit, when one does an audit, clinicians examine their practices and results against agreed explicit standards. And the process is modified where indicated. There are standards, like Dr. Rana's talked to us about, there are emergency standards. So if one takes a standard and sees if you are following that standard. So an audit is done according to a standard, and then it is audited to see if we're actually following that standard. Because if we just do an audit and don't have a standard to go by, we will not really know what to assess. So then the process can be modified if we're not exactly following that standard. So it is a structured process, and it ensures best practices by reviewing what we are doing, compared to what we should be doing. So very often, we don't really know, we think we're doing the best. We don't really know what we should be doing. So that's where the importance of an audit comes. So to simplify it all, to audit is to study a clinical process, identify the inadequacies, if any, in that process, and rectify that process based on your audit findings. Okay, so why is audit so important? Because it's all about improving patient care, and it is a very powerful tool for change. So if all of us in this, at the end of this, just take home that audit is a very powerful tool for change for the better, then it's worth the 20 minutes of this. So how does one bring about the change? When there's a deficiency in patient care, generally there are broadly 3 areas where change can bring about an improvement. So any deficiency in patient care would be because of an organizational reason, education, that is, do we need to educate ourselves more? Do we need to educate people around us more? And resourcing, do we need more resources? So when you choose an audit, you choose a topic that will address one of these 3 areas, and then you can aim at changing that area. So a well-designed audit targets which of these areas needs to be addressed, and you can't just change organizational, organization. You can change it if you have some proof to show that a change will help, or if you have some proof to show that because of this organizational flaw, we are not able to carry out what we are carrying out properly. So an audit provides strong objective evidence. You can't just go and say something without evidence in this day and age. So what are the different types of audits? We are sticking to clinical audits. The different types of clinical audits are standard-based audits, which is the recommended process. So its current practice is compared against defined criteria or best practices by using an audit cycle. Or you can even have a significant event audit. You find that you're having some events in your department. Say wrong drugs are given, or just to mention a very simple event. So it's a significant event audit or adverse occurrences, critical incidences, unexpected outcomes. Or you can audit problematic cases which are causing you concern. You can review it systematically and solutions are implemented. So anything, any concern that you have in the clinical area can be audited. Because remember, the aim is to improve. So how does a clinical audit help improve patient care? It reviews the quality of services that we provide to our patients, and the cause for departure from best practice is studied. So if we are not doing what is advocated in best practice, there must be a reason. So we are studying this reason, and an audit helps us rectify these reasons. Improvement of deficiencies observed in that particular process is then worked upon. So what does it do? What are the other benefits of an audit? It enhances staff professionalism. It increases resource utilization efficiency. So we might find that we are not actually utilizing our resources efficiently. And it aids in continuing education. It also demonstrates accountability to those outside your actual ED. So it tells administration about your accountabilities. The very fact you're auditing your own processes shows that you feel accountable for what you're doing in the ED, and you feel accountable towards improving what you're doing in the ED. So it's called a cycle. Stages of clinical audit is a cycle because you start with the audit and you actually come back to the audit. So I'll go into that. So it's a cyclical process of improving the quality of clinical care. So stages of the process can be summarized as what should be happening, what is happening, and what changes are required. And as the process continues and repeats itself, each cycle aims at a higher level of quality. So it is a spiral. It spirals up rather than just a loop, or it should spiral up rather than just a loop. The first stage is to prepare and plan for the project. So in any walk of life, or any project or anything that you undertake, unless you plan and prepare for it, it's not going to work properly. So they are essential elements for success in project management, not only in an audit, in anything. And we must know that the principal aim of our audit is to improve healthcare. Therefore, the effectiveness of the proposed audit in promoting improvements should be the first consideration. Is this audit that you're going to do improve the whole process. So that should be the first consideration. And there should be clear, realistic aims and a time scale in place. Unless you have a time scale, it's not really going to work, because if you overshoot your time, then it defeats the whole purpose of having the audit. An audit team should be formed. So if you have an audit team formed, so that's more than one person taking an onus in anything that you do. If you have a good teamwork, then it ensures success of whatever you're undertaking. So if you have an audit team, someone from the organization, someone from the doctors, the nurses, even the housekeeping, even the helping staff. So that team should be formed to assess feasibility and to identify the requirements that you'll probably need for the audit, like manpower, skills, training, communication, resources, and implementability. You need someone from IT. So audit is supposed to promote a culture that supports and encourages audits. So your department is supposed to promote a culture that supports and encourages audits. So audits very often are seen as a threat for criticism. So you're scared if you're honest about what has happened, someone will critique you, they'll criticize you, you might be punished. So audit can be regarded as an unpleasant, time-consuming distraction from your busy daily practice. And I'm sure a lot of us, including myself, when I first started doing audits, and even sometimes now, feel that it takes away so much from your daily practice, but it is important. A successful clinical audit requires effective leadership, commitment, transparency, and teamwork. So unless everybody's committed and there's good leadership, audits will not actually show you what it should show you. It requires skill, training, and time. And organizations also must recognize that improvements resulting from audits can increase costs, because very often when you implement the change, it involves a cost. And now, thanks to NABH and all quality improvement, the QAI bodies, institutions do want to get accredited and are willing to invest to improve services. So an audit is a very good means to showcase to the management what exactly we have found and what we need to do to improve. So second is to select a topic. You identify relevant issues that need to be improved. There's no point auditing processes that are already in place. So if you have a process that you think is working well, don't choose that as the first one. Choose something else that you want to improve. So you can select topics like go through your critical incident reports, and that can be one of your topic. Adverse events, complaints, feedbacks, direct observation or direct conversation with people might give you an idea about what audit you want to have. So selection is based on a number of factors. One is impact, high risk to staff or patients, high volume, high cost, new policies or new protocols. The seriousness, there is high complication rates, patient complaints, good evidence available for standards. So you can do systematic reviews, national clinical guidelines, and base your audit on those guidelines. So on what basis are you doing this audit? On proper established guidelines, problems amenable to change, and find out if the improvement from an audit is sustainable. So just to give an example, if you're going to audit the strokes, the way you see strokes, you know what the national guideline says about management of stroke, early management of stroke. So if you're following those guidelines, it's easy to audit it. Define criteria and set standards. So the standard you set for your audit is a minimum level of acceptable performance for that criteria. So it can be a percentage of events that should comply with the criteria. So if you're auditing 100 patients, you find out what percent of what you have audited should comply with the standards. And you can refer to best practice, clinical performance indicators, systematic reviews, again, national clinical guidelines that are available. Benchmarking techniques helps us to avoid setting unnecessarily or unrealistically very high target levels of performance. So in your first audit, if you set very high target levels of performance, you might be discouraged if you're not meeting it. So it's good to increase your target levels slowly. Audit criteria, clinical audits usually look at processes, record keeping, adequacy of documentation, and use of investigations. They can also look at outcomes like surgical complications, deaths, patient satisfaction. The measurement of outcome can be used to identify problems and find out if the outcomes are clear, if they are influenced by a process, and if they're likely to occur within a short period. So don't take something where the outcome is going to happen after a very long time. Take a outcome that is short enough. Then the fourth stage is to collect data. Information can be collected either retrospectively or concurrently, although retrospective is more common. Data can be obtained from computers, clinical records, questionnaires, adverse clinical reports, or data abstract forms. And multiple sources of data are advocated because that improves the completeness and accuracy of your audit. Consider ethics, consider confidentiality, including staff confidentiality, before you start to collect the audit sample. Now, in rapid cycle sampling, there's something called rapid cycle sampling, where you take a small number of samples and you collect it repeatedly over short periods of time. What does that do? It helps to test effect of change on a small scale implementation. Then data collection, again, information management and technology has revolutionized data management, and electronic data is likely to be much quicker and more accurate. Also, computerized patient records will provide audit data automatically and continuously, allowing immediate and instantaneous access to current levels of care for monitoring performance and performing regular feedback. Again, if we take stroke as an example, from or a patient coming with chest pain to an emergency department, because we have everything computerized, you can exactly know the timing as to when the patient came in, when the ECG was done, when he was admitted to the cath lab, when the thrombolysis was done. So proper records, accurate records are available because of computerization. Just to share a few examples of emergency medicine audits: patient revisits for the same complaint, length of stay in the ER, bed utilization, triage time, time to pain management, patient satisfaction, time to thrombolysis, death and CPR audits, and document audits. It's very important. Adequate, complete documentation is very important. Stage 5 is to analyze your results. So the data collected is compared with the set standard to see if improvement measures are necessary or are you within the set standard. Statistical analysis is not required usually for an audit. And like I said in the previous slide, rapid cycle data collection and analysis is very successful in monitoring your improved performance. The 6th stage is to identify solutions for improvement and to implement changes. So a report should be generated together with recommendations for improvement. So recommendations for improvement is very important. And this should be presented at an audit meeting in which all stakeholders are available. Like I said, an audit is only meant for improvement. It is not meant for punitive action. So the discussion should be truthful, educational, and constructive. It should address both clinical and administrative issues. Okay, so it's good to follow the no name, no blame approach. Okay, finger pointing, punitive action discourages reporting, and many valuable learning opportunities are thereby lost. So the aim should be prevent future errors rather than punishing past ones. So why am I talking so much about this? Because very often people are, they don't like doing audits because of exposure that can happen. And remember that most of the time, the fault lies in the system, not really in an individual. If we have our systems in place, our processes in place, then things go on smoothly. A frank discussion will generate options, ideas, solutions, and will secure staff commitment to improvement. Strong leadership, again, is very important, and commitment and participation of all staff, especially also representation from senior management, is very vital for success. And the last stage, which is stage 7, is to re-audit to monitor the impact of the changes. So you have to close the audit loop. So I said it's a loop. So why is it a loop? Because once you have your findings, you do another audit. So you re-audit and see if you've improved on your previous audit. And then it's also a spiral, because each time you should aim at doing better than the last. So the cycle should be repeated from time to time as a spiral till the target level is achieved satisfactorily in order to sustain improvement. And emergency physicians should take a role in auditing both new and old clinical activities and continue to re-audit. Just because you've had an audit, you've done it satisfactorily. Maybe after a couple of months, or maybe in a couple of years, you can re-audit the same thing. So to conclude, an audit aims at improving patient care. It should lead to an improvement in the quality of clinical performance. The key to successful auditing is careful planning. All ED staff should be involved in the entire audit process. Different stages of the audit cycle should be followed. And as a quality improvement tool, clinical audit is one way that showcases that real efforts are being made by dedicated professionals to deliver high quality patient care. So thank you for your patient listening. And if there are any questions, I'll be very happy to take.
Yes. So again, thank you for the patient listening, and I'm happy to answer questions.
Ma'am, thank you so much. There are not many questions in the chat box, but however, I got something to ask you in terms of clinical audit. First, thanks for taking us through this fantastic 6-stage process of audit. But since there are many young emergency physicians here and many of them run academic training programs, this question is specifically from their side, you can say. See, many a times we confuse this audit with a research publication, right? So whenever you ask for an audit, they actually think of a research project and a long-term project. Ma'am, can you kindly take us through what is the difference between, say, the audit versus an actual research or a thesis which they are trying to do in simple terms?
Yeah. So, and you can hear me, Srinath? You can hear me, Sarvana?
Yes, ma'am. Yes, ma'am. Please go ahead.
So what an audit is, okay, I'll tell you about a research. Research is a question. So you ask a question, or you have 2 drugs and you want to see which drug is better, or you want to see whether what happens to the blood pressure when you give something, just to be, very simple. Or you're trying 2 different pain medications and you're seeing which pain medication is better in a particular patient, or for procedural sedation. You're maybe trying a block and you're checking out how the block is acting with 2 different anesthetic agents. So that you can say is research, or if it's very simple, then you can also maybe say it's a thesis topic. So you are not checking whether what you're doing is according to the standards. Now, for research, you need statistical analysis. Now, an audit is different because, just to give an example, you have a patient with chest pain coming to your department. What do? You quickly do an ECG immediately. Within the first few minutes, you have to do an ECG. You have to give whatever pain meds, your aspirin, your Disprin, your antiplatelets have to be given, and the patient has to be moved to the cath lab. So your door to balloon time should be minimal within the stipulated time limit. So an audit will check whether what you're doing in your emergency actually follows this process. Are you actually meeting your door to balloon time? So an audit is something that checks whether the processes that you are doing are within the benchmark. So you are auditing, you're checking your processes. It's different from research. So when we ask for research topic is different. An audit is different. It's just to see that what you are doing right. Anything you want to add, Sarvana?
Ma'am, I think you have answered it very, very nicely. Thank you, because this has been an ongoing confusion in many departments, and I think you put it up very clearly. Thanks a lot, ma'am. There are no more questions, and I think we will move on to the next one, and I hope you will stay on until the end of the program.
Yes, I'll be here.
Yes, ma'am. Thank you.
Okay, yeah.
And let's move on to the next speaker for today. Dr. Rana sir is here, I guess, and we already introduced him, but I'm more than happy to introduce him again. Sir, are you here? There he is. Yes. Sir, very good afternoon. Thanks for joining us. And for those who joined late, Dr. Rana, many of you know him from his NABH days as a former CEO of NABH, when currently sir heads the Quality Accreditation Institute. And what's important is we have got a good, strong relation and collaboration with QAI. And in fact, SEMI and QAI have recently drafted the ED department standards, and currently we've got 4 departments who underwent the accreditation process, and I think many more will follow soon. And we will invite Rana sir to take us through why accreditation actually helps in improving quality in emergency departments and importance of accreditation. Rana sir, over to you, and welcome, sir.
Thank you so much. Can you hear me?
Yes, sir, we can. Please go ahead, sir.
Great. Thank you so much. Just give me a second. So thank you so much, Sarvana, for introducing me, for your kind words. And thank you very much for having me here in this workshop. And my really apology for, things have gone out of my control, so I just delayed. But things are now back in order. I could set things up, and I'm just going to share my screen with you all. Yeah, so my screen up. Okay, great. Thank you so much. So now the question which is asked is why emergency department accreditation is important. And I thought just to, let me capture some of the reflections on this. So, so just to start with, Quality and Accreditation Institute is a very young organization, a budding healthcare accreditation organization in India, and started looking at different perspectives and different standards. So currently we have around 14 standards, including emergency department accreditation standards. And thanks to the Society of Emergency Medicine India, SAMI, for the collaborations, and thanks everyone around on the technical committee for bringing out these standards. And one more product which is underway at the moment is the Stroke Care Accreditation Program in collaboration with the Indian Stroke Association. So this is our menu quickly to reflect on what we have been doing for the last 5 years. And we are really proud to say that the QI is the only accreditation body in India to achieve interglobal recognition from ISQA in less than 5 years of operations. So we are, as an organization, recognized by ISQA as an accredited organization. And we have 2 standards, dialysis and home healthcare standards, also accredited by ISQA, making us the first and only accreditation body in India having 2 sets of standards accredited by ISQA. And most importantly, the good thing is after ISQA accreditation of organization, QI accreditation is recognized by Central Government Health Scheme, CGHS, under Ministry of Health and Family Welfare, equivalent to NABH accreditation for empanelment of private hospitals, eye centers, dental centers, and imaging centers. So these 4 categories of healthcare providers can get the similar benefits from QI accreditation as they will get from NABH accreditation for CGHS empanelment. So this is a big boost for QI as well as any healthcare providers for choosing the options. Quickly, we also have an option, the program for medical laboratories. Many of your hospitals are accredited by NABL for their laboratories. So we also offer medical lab accreditation programs similar to NABL. And now I can say with proud that QAI accreditation for medical lab, testing lab is equivalent not only here in NABL, but globally, because we have just on 31st of October received full membership or signatory status of mutual recognition arrangement from Asia Pacific Accreditation Corporation. So we become the second Indian accreditation body in India's history. And I'm really proud to say it's happened 22 years after NABL got in October 2000. And it is a really proud moment for me that I was part of NABL team in October 2000. And now I am part of the team of QAI to receive such recognition. So these are certain things which we could bring to QAI for recognition. We also publish a journal, Healthcare Quality and Patient Safety, for anybody to publish their work free of cost, no charge for authors. Now, coming back to the business, what we're talking about accreditation, as you know the definition, I just trying to remind everyone around is accreditation is nothing but a recognition of achievement of a standard.
We can't hear Dr. Rana.
But we lost him. Looks like we have lost Dr. Rana. And let's give him a couple of minutes to join.
At the end of the session, we will be having a Kahoot quiz. So to participate in the quiz, it's better to join via PC. So it will be easier. Otherwise, in mobiles, it will be difficult.
Thanks, Naveen. I think Rana sir is back. Sir,
So
back.
the question is why accreditation for emergency department? And as we started asking, so people around the table understand why and what are the benefits. Quickly, what are the benefits for patients? So they get high quality of care, they get safety ensured, they get treatment from credentialed medical and nursing staff, they have rights protected, they have good satisfaction level, which can be measured by organizations, and they can reflect on their satisfaction. And most importantly, it's a person-centric care. When we talk about disease treatment, patient treatment, we say person-centric or people-centric care, where a lot of focus is around patient and the family and the community. Similarly, what are the benefits for emergency department? So it's actually helps in demonstrating the commitment to deliver quality and safe care. Also, it helps securing and assuring the community that this hospital's emergency department is accredited. It means they have something extra compared to any other hospital emergency department to offer. This also helps in building a transparent and ethical system for delivering the care. And most importantly, for any organization, emergency department, it's really help in understanding the risk management. So risk management helps in risk assessment, risk mitigation, and therefore really help the organization in a total goal of achieving a risk-free system. And also it helps putting organization on a continual improvement path. It helps that organizations should learn and practice newer things, innovative things from their own experiences. Not they need to get everything from outside. Whatever they have been doing, they can learn from those, even from good things or from some errors, and can improve upon them. And also it helps in a way of self-regulation, right? That yes, I want to be following a system, how I can get it into that. So the standard for accreditation helps in putting that system in place. And also, the most importantly, there may be an opportunity for benchmarking. So maybe there are 10 ED in 10 hospitals, they are looking for some benchmarking. Then I say, okay, my turnaround time from my door to next procedure room based on a specific protocol is this much. So how it is compared to your hospital to other hospital emergency department. So you can really help getting the benchmarking and then move around. Similarly, for the staff, it's important because they get an opportunity for professional development, because the standard asks the organization to provide the professional development for the staff. They also get a good working environment, they get the opportunity for leadership, and most importantly, the ownership of the processes. They say, oh, this is your process, you own it, you are responsible, and you are master of it. And also help building their confidence to deliver the proper care. So if you make sure that your staff is safe and from all the things, like in COVID, it happened. A lot of staff was afraid of contracting COVID from patients. And if you don't assure your patient, your staff, that you are being provided complete PPE and all the safety protocols, please focus on patient care, they won't. So it is important that you really inculcate in a habit of safety in the staff as well. Similarly, for any other stakeholder, it helps as a system for objectivity, because there is a system in place, there are documentation, there are evidence of things being performed there. So they can really rely on those information which is available because they are already documented. So it's really helped the third party, the stakeholder. Now, I'm moving to the slightly a different perspective. Now, let's ask some questions. And these are not the all questions. These are some of a selective theme I could pick up from some of the samples. That let's ask some question ourselves. The first question is it necessary that emergency escape routes throughout the department are marked and emergency exits are clear? Okay. Do you need to keep laryngoscopes, ambu bags, and other equipments in a sterile manner? Do you need a periodic maintenance of equipments in the ambulance which you are operating? Should the ambulance be disinfected regularly? Shouldn't there be a handover process and records of such handovers for doctors in ED? You will find for nurses, but what about doctors, right? So these are questions questions we are asking, and then I will ask the answer from you only. Shouldn't the signatures, date and time documented in the written case sheets? Shouldn't there be panic value intimation at both the ends, mentioning caller name and the receiver name, patient details, and the information which is being conveyed over telephone or on a voice media? Shouldn't the nurse to clinician time on conveying information regarding panic value be established? That how much time you would take when you come to know about the panic value, how much time you will take from the lab to patient to the clinician and clinician to who actually is providing the care. Shouldn't there be a proper triage screening process for communicable disease in the triage area? And it has become more important after COVID, right? When the patient comes into the area in emergency and you are doing triage, are you only doing for the complaint, or this also include the communicable disease, because that's become important nowadays? Shouldn't there be policy and procedures in place for care of patients under special conditions as restraints? So there may be patient under physical and or chemical restraints. So do you have something for them specifically to deal with? Shouldn't there be defined and documented clinical protocols and pathways following during transfer, which are available in ambulance? So when patient is transferred in an ambulance, so can you leave the patient like this? You don't provide some care within the ambulance before it reaches to the emergency department of the hospital. If you think so do you have the protocol and pathways available which can be followed and the people really know how to use them? Shouldn't ED maintains an inventory for medication? And it's very important because some medication may be fast going out. So are you able to push back those medication into the system so that you don't get out of the system when you need them? So how seriously you really maintain that? Shouldn't lookalike medicines stored separately? Because this is some of the high risk things when the lookalike medicines really pose threats, and instead of A, you give B. So how you really make sure that they are not? So this is the question we ask ourselves. Shouldn't you ensure that emergency medications are available in the ambulance? So when an ambulance is ferrying the patient and you make sure they have the necessary emergency medication, not the expired medication or not the near expiry medications. Shouldn't all stored medicines and reagents used in the preparation be labeled? At times you prepare medication with a combination of different drugs. So do you really label them with what the content inside? What is the expiration dates for that? And is there any warning you need to put on that so that anyone who's going to use follow those warnings? Shouldn't there be a policy and practice on storage of concentrated electrolytes to prevent inadvertent administration, sodium, potassium, right? For example. So not only having policy, but the practice, the use, the implementation of that policy is very important, where how and where you are storing to prevent any inadvertent use of those strong electrolytes. Shouldn't be medication orders clear, legible, dated, named, and signed? Shouldn't high-risk medication verified before dispensing? And please mind that the medication errors are one of the largest cause of deaths and adverse incidents in medical area all over the world. And that's why World Health Organization taken medication safety as a global patient safety challenge this year on World Patient Safety Day. Shouldn't all staff practice proper hand hygiene? And when you go to hospital, emergency department, or any department, and you will say, how much is the compliance for hand hygiene? People say 80%, 90%. And how it is measured? And I always give an example that you really measure how you do it from the amount of disinfectant you consume. So you have 1 liter of a disinfectant, or use any liquid which you are using for cleaning your hands. How much it is consumed in emergency department, and you back calculate it, right? But actually, at times you are really wasting that because you are using it, but you are not properly using it. So all steps of cleaning hands, if you are not following, perhaps you are just wasting that disinfectant which you are using. So my question go back to them is that now tell me how much compliance for proper hand hygiene, not the hand hygiene, right? And then it goes down from 80% to 50% immediately, and it can be evidence, particularly when your clinician is walking from one patient to another patient, whether he is really cleaning his hands before touches the patient. Same thing is about segregating the biomedical waste at source, right? You have an arrangement with an agency, you come pick up your waste and dispose it off properly. But what about your segregation when you are at a point of generation? Are you really seriously following it? And these are very serious issues because they are related to infection. They are related to the safety aspects of patient as well as the staff. Now, see, these are some of the questions. There may be n number of questions which might be listed like this. So now my question to you is, if the answer to any of these questions is, then ED accreditation is important. And you can reflect in yourself that, do you dare to answer no to any of these questions? You know, so if any of the answer, n number. Now the second thing, you may say, no, this is not important because we are doing it. Fine, you are doing it, but how much you are doing it? How many of you are doing it? See, if you're saying I am doing the trials for patients for communicable diseases, so how many patients? 100%? Everybody coming to your hospital, you are doing trials for the communicable disease. If you miss out on in even a single patient, it means you are not doing 100%. Similarly, hand hygiene example I have given. Similarly, I can say, oh, I check medication before I dispense. How many? All? If you say no, then you again miss out. So whatever questions I have listed out here, you have to follow 100%. You know, when I say 100%, you go to near 100% if you're not exactly absolute 100%. But you can't take that 70% cases I'm doing lookalike, but not 30% cases. 70% cases I'm checking my ambulance before it dispatch that it contains all the essential equipment it should have, all the medication it should have. It is disinfected properly. I'm checking everything only 7 times out of 10. 3 times I'm not checking. So what happened to the patient when it comes to 3 on those occasions of the patient faring into it? I'm checking all my equipment. They are kept nicely, neat and clean. They're coming from CSSD, but at times I have opened it, but I have not used them. So if you have not used them, then throw them, get it sterilized again and bring it back. But no, you don't do that. You use it. So what about that patient who is going to use these already opened ambu bag or anything which need to be actually made sterilized? So these questions is not just only reflecting on the practices, but also the quantity, you know, that the number of times you really practice. And in healthcare, when you ask question as a surgeon, what is your success rate? And you say 99%. Fantastic. But what about that 1%? For that 1% of your unsuccessful surgery, that patient is 100%. That patient who undergoes 1% unsuccessful thing is, for him, it is 100%. So in medicine, it's not something which you can really look at less than 100%. Everything needs to be. Of course, there would be some leverage, but those is unintentional, right? So things here are, still I say, still many answers would be a no as far as documentation and implementation is concerned. So there are steps. So do you have some policies? Do you have some procedures? Do you have protocols? We call it documentation. Many times you may say yes, but when we ask the next question, do you really practice them? Do you really follow them? Do you implement them? Then answer may not be yes always. Right? So we actually miss out somewhere in the implementation science. We have beautiful policies, procedures kept, but we miss out on the implementation aspects of those documents. And that's why when say, oh, Dr. Sarona, your handwriting is so beautiful, you write so nicely, but why you write TDS, BDS, NS, HS? I don't understand what does it mean. Why don't you tell me before night, during or after breakfast, or 3 times a day or 2 times a day? I really don't understand what you write, right? And then Sarvana come back, no, why you're asking me to write the time? I said, simple, because if you don't put time, how the next person will understand at what time this medicine was given? Which is an emergency is very important, because you say every hour you have to be giving this one. So if you don't put the time, then the next dose will not be estimated. So that's why the time is important. And then he again shouts on me and he said, why you want me to put my signatures? I say, I want who has put it. I want to know who is the gentleman or lady here who is prescribing medicine, so that I know. And in case I need to talk and contact, then I can. It's not only patient, but any healthcare providers, the colleagues itself. So this has become important. It's not an emergency department. As you know, in any emergency, there's a first contact point. before they go into the deep of the hospital for any further investigation or a procedure. So your department is the most important, because you decide this patient is for a stroke. And it reminds me my discussion with the technical committee for stroke care, that how important, I asked the question, how important for you is the emergency department? They say the most important. Because when we say we are good in our golden hour, door to needle and door to puncture, door to whatever it is, but it depends on my emergency department how efficient that is to recognize that this is a patient of a stroke and this is what is to be done, and send it for the lab investigation or for any radiological investigation, so that my stroke team can take over and do the necessary job. And that's become my success, because their time is important. So this is very important. And it's, so everybody says, oh, we are doing it, but unfortunately somewhere we don't. We want to, but we don't for some reason. And therefore we need an oversight mechanism. That's where the role of accreditation comes in. Okay. So if you look at this table, this beautiful table, and I compliment the technical committee for the emergency department, support of SAMI, of course, brought out this beautiful set of standards and list out these 10 chapters. And the question which I have shown to you comes from all of these 10 chapters. It talks about how the governance is, how the leadership function, how is the commitment from the management comes into to provide you adequate resources in terms of the services which you are offering, how your design and facility management works. Is your emergency department is structured for a smooth, transparent journey of the patient in a manner that it is good for them, or it is so clustered, you don't have sufficient space, you are not able to manage the patients? How about staffing and training? What type of staff you need, how many numbers you need, what training specifically they required, information, education, and communication, how you collect information, how you store information, how you retrieve information, how you disseminate information. Everything is important in that. And that's also efficiency. Documentation and information management system, how you really document all your systems. Continual quality improvement, you define your performance indicators. That my turnaround time to receive patient and send it off from my department to there is 30 minutes. Okay, measure it. I check on all these parameters within this. Okay, do it. So this helps you measurement and then improvement. Of course, specific to triage and assessment management and disposition, how quickly you do triage, identify the necessary need to specific patient, and then send them off for further procedures and investigations. Emergency medical services, maybe it is out of your hospital and ambulance comes in. So it's pre actually emergency department services. So how you really manage, coordinate with the ambulance services, which brings patient to you. And then, of course, medication management and safety really plays very important, because everyone in emergency department in hurry, because patient needs immediate attention. So everybody is rushing to take care of the patient. And in that situation, in that physical and mental status of staff, you can say how important it is that they realize that right medication, right time, right dose, right route, and right patient need to be adhered to, because they are really under pressure compared to any other department. And of course, last but not the least is hygiene and infection control at all time. At all time, it's not an exception that you can't, you just follow the good practices for hygiene this time and not the next time. So this whole framework of standard actually helps emergency department to structure their processes, structure their outcomes, and really work on the improvement. And that's why the process for accreditation helps. So you want to do something good, you are doing something missing out because nobody is watching. So if there is an oversight mechanism outside the organization, perhaps that helps you, supports you in implementing more and more policies and adherence to compliance and more. So that's why an external evaluation mechanism, which is an accreditation at the moment, helps emergency department to help and sustain. And this is what it is, a golden seal of mark of sustained quality. When any staff look at it, organization look at it, public look at it, patient, they get a sense of confidence. Oh, this is the department provides services which are beyond what we expect. They have certain protocols already evaluated by somebody else, from external evaluation process. So at the end,
this is what I can say, thank you, because you made life easier for people when they walk into emergency department, because they are panic. That's not planned. They are not visiting emergency department as a planned activity, because they are visiting unplanned activity. So they need a lot of support mentally, physically, clinically, and therefore is an oversight from external agency really help and support bringing everything what you as a good organizations are looking for. So thank you very much for giving me this opportunity to talk and share some of the insights and reflections, in order to improve our emergency department in various hospitals, recognizing the fact that many of the hospitals are already into the accreditation system. However, still they need improvement, because this is a specialized area. In whole of the hospital accreditation mechanism, they may not be focusing much on that, but they may have a basic infrastructure and process in place. So this specific accreditation program really helps in strengthening the emergency department's functions and support the people working in there and their patients for the better outcome. So thank you very much, Savana. Thank you, Srinath. Thank you everyone around for giving me this opportunity. Thank you very much.
Sir, thank you so much. I think it's always a pleasure to listen to you. Of course, your contribution for quality is clearly unparalleled. And thanks a lot for giving us an opportunity to work along with QAI to come out with those standards. And clearly, I think it's a huge landmark step forward for us as a society and as a collective specialist group to improve quality of ED care in the country. I didn't see much questions in the chat box, but however, I got a quick question to you, sir, if you can kindly take a couple of minutes. I think this is something which we commonly hear from many of the colleagues, that why we need a department-specific accreditation when we have, and say, a hospital which is accredited. I know world over we are moving more towards department-specific accreditations, and of course you know this space much better than any of us sitting here. What is your thoughts about it, sir? Where are we heading towards?
Very good question, Sarvanar. At the end, as I touch upon that the hospital accreditation is a hospital-wide accreditation, because it's not specific. So it provides general oversight on the entire hospital, right? But in the specific cases, it really helps to looking into that area specifically with the specialist expert on that standard. So it's like, if I give an example, like when you do the MBBS, you are licensed to practice medicine, but still you go for a master of surgery, MS or MD, right? And you become a master in medicine or surgery, still you can perform legally, you can perform many surgery, but still you say, no, this is not something I really go on to. Then you go for MCS neurology, neurosurgery, MCS cardiothoracic surgery, or DM cardiology or neurology. Why? You specialize things and you learn and more. So as you improve in their area, become focused. And then if somebody asks, oh, what is this? This is about, you can, as a neurosurgeon, you can talk about it. You may not talk about that length and depth when you are an MS or an MBBS. Similarly here, when your hospital is accredited, there is a system in general, I would say, right? But not necessarily that everything is covered in depth. And that's why in a department specific or a disease specific or a program specific accreditation program can help and support, particularly in those which are more critical, like emergency department, right? Similarly, why we started a stroke? Because the Indian Stroke Association think that the stroke is the second largest cause of death. So why not to work? And I think I'm really happy and honored that say QAI is the first organization here in India to start a disease specific accreditation program first time. Stroke care, advanced stroke care centers and primary stroke care center. So I think that is how the importance is, because they are more life-threatening, and the time and the clinical competence play a huge role for the outcomes for the patient. Right? Little delay here, like in your emergency department, if your team is not able to identify that there is a stroke patient, then now you can assume what will happen to the patient. Despite you have the best neuro or stroke team available, they may not be able to do, because the time which they were requiring has already gone out of their hand. So that's why it is important for you as an emergency department to really send complete support to the rest of the department. Is that you as an emergency physician, nurse, and paramedics, they should also feel privileged. They also feel proud that, because we put this extra effort into our department, we get recognition, but most importantly, now we are able to provide better outcome to our patients. So I think that sense of contribution to the community is a great sense of help, which we as an emergency department can pay off.
Thank you, sir. I think that's a great answer. I think many of them who had this question in mind, I think we got a very clear answer today. And I think on behalf of SEMI and all of us, thanks once again for joining. And also congrats to QA, because perhaps you are maybe one of the only organizations across where you involve the specialist group or those who are the actual people on the ground on this particular specialty to be a part of this entire mechanism. And thank you for doing that, sir. I think
that's really wonderful and challenging. Bringing the neurologists on the table for 3 hours for a meeting, they say how much time we need. So we are practicing neurology. Okay, no, if you want to be in the system, you have to really contribute. So I think that is very important, and we are happy that we have support of experts like you and the neurologists. We are coming forward. So thank you so much, Sammy, and all of you here for listening and providing the opportunity to share. Thank you.
Sir, thank you so much, and you're most welcome to continue to stay with us, sir. And we have the next speaker who has joined in, Lallu ma'am, after a lot of difficulty. Ma'am, I have introduced you already, but it's always my pleasure to introduce you as my teacher more than anything else. But for those who are here, clearly Dr. Lallu represents both CMC and as well as CAHO as its National Secretary. Ma'am, it's a pleasure to have you here with us. And I know you had, this is perhaps your third or fourth talk for the day, but thanks for taking time to join us today, ma'am. And over to you, and we are looking forward to listen to your topic on building culture of safety, which is very, very important, not just for EDs, but across any organization. Ma'am, over to you.
Thank you. Thank you so much, Dr. Saravana. Am I audible? Is my presentation visible?
Yes, ma'am. Please go ahead.
Thank you, Dr. Rana. And my apologies to all of you. It's been one day. I just don't know how to explain this day to you. It's been running from pillar to post. And thank you so much, Dr. Saravana, Dr. Srinath, for accommodating me and my erratic schedule today. So I'm going to be talking about the building the culture of safety. See, we all talk about culture of safety, but how exactly could you go ahead and build the culture of safety is the big question. Because when you go for accreditation, it is a one-time, people think it's a one-time exercise. That particular day or the 3 days or 4 days, everybody is in the best of attire. Everything is all right. Beyond that, what is expected is to build that culture, which is sustainable, which is in that organization, even when no one is watching. So how do you go about doing that is $1 million question. So I'm just going to try and see, how we could do something. Now, when we talk about culture, the best phrase that comes to our mind is the way we do things around here. That is actually the culture. This is how we have been doing. This is how we do. The way we do things around here. That's the culture of the organization. When it's one person's attitude, it is just an opinion. Dr. Saravana's opinion is this. But when something becomes everyone's attitude, then it becomes a culture. That's the simple definition of culture. So when one's attitude, it is opinion. When everyone's attitude, it is a culture. That's the simple way to go about it. Now, we need to first understand the safety culture in our country before we talk about anything. So we all know how we travel in our roads. This is not an uncommon scene, particularly for emergency medicine physicians. I'm sure you come across this on a day-to-day basis, accidents after this kind of a travel. And this is something, our own Mumbai, this is a picture from the trains there. And this is a common sight in our country. So with this culture of safety in our country, we are talking about healthcare and safety. So you can imagine the culture of our employees, our doctors, nurses, technologists, administrators, everybody. So that's the culture with which we are trying to build a patient safety culture. How challenging is that? And how to do that is what I'm trying to be focusing on. Now, we all know about the problems in our setting. It's not new to Indian healthcare. Healthcare and safety, we know the statistics very well. When compared to a plane crash, to a error, medical error, the ratios are glaring. 1:300 versus probably 1:5,000 in a car accident. Okay, so that's the ratio that we are talking about. And these estimates are very glaring. We all know this figure. We've been talking about it for the past 10, 13 years. WHO estimating 1 in 10 patients in developed countries are harmed, AHRQ report, IHI report, and still we have no report from our country about how hazardous is healthcare because we don't actually capture data. So we are not able to say how hazardous it is in India. But typically, when 1 in 10 patients end up with a harm in a developed country, it is probably 5 in 10 in a country like ours, which is developing. So therefore, we say healthcare is hazardous. It is not like the airlines industry when we get very scared when we get into an aircraft. But in a hospital, it is equivalent to a bungee jumping and it's even more unsafe. Failures in healthcare delivery are not uncommon. Hand hygiene aspects, personal protective equipment usages, very negligent, medication administration errors, patient identification errors, surgery on wrong side, retained objects, fires, wrong gas connected. These are all very major failures in healthcare delivery that we come across. I always quote this lady when I talk about patient safety and the culture of safety. This lady, this pretty lady, it's not about her and her 27 plastic surgery, but it is about her mother who underwent a surgery in one of the leading centers, Sloan Kettering in Manhattan, who had the wrong side of the brain operated in 1996. So that was the time it came into the media and everybody started talking about it because it's Sridevi's mother. But today, there are many things that are reported and many that are not reported. So this lady, I think when we look at it as clinicians, nurses, we should think about the state that this lady went through when her mother had this kind of a wrong surgery performed. And these are some things that I have pulled out from our own incidents. AMRI fire that happened was a glaring example in front of our eyes about the culture of safety. Imagine patients dying because of a power outage in a hospital because they actually did not know how to how to disconnect or do what to do when the generator supply stopped. All these are not uncommon to our setting. So with all this, the challenges faced by hospital today are far too many. First and foremost, medical negligence. Our patients are becoming extremely aware. Google is making them extremely aware of the situation, and the patient safety litigations are on the rise. Increasing expectations of patients. They treat hospitals like hotels today. So their expectations are far too many. The expenditure is too much. We are not able to cater to their needs. So therefore, the expenditure is also increasing. Lack of skilled manpower and our attrition is very high. Inability of an organization to sustain is a major challenge for us, and we are seeing many small and medium hospitals closing down. And most important thing is our own culture of risk management and safety culture, which is actually becoming a major challenge for our hospitals. So what we need to remember here is, if we have to sustain, if we have to be good in what we are doing, we need to have sustainability in our culture, the patient safety culture. It's all about sustainability of the organization. What is sustainability? It is the capacity of organizations to be able to meet all these changes and variations over time through a process of continuous improvement. That is what is sustainability. So other culture of safety is the safety culture. If you look at it, only if you have the safety culture, then you are going to have a sustainable culture in your organization. Safety culture, I mentioned about it in the beginning of my presentation. But however, by definition, safety culture is viewed as an organization's shared perception. It is not one person's opinion. Organizations' shared perceptions, beliefs, values, and attitude that combine to create a commitment to safety and an effort to minimize harm. So this definition is a beautiful definition. It's everybody's efforts, shared values, beliefs, attitude, perception, all those combined to create a commitment to safety and an effort to minimize harm. Now, early adopters of the culture of safety are what we call as the high reliability organizations. It's called HRO. Which are these high reliable organizations? Typically, they are the airlines, mining industry, nuclear power plants, which cannot have a failure. So these high reliability organizations are highly complex organizations. They are very highly technology adopters. Basically, they are technology intensive organizations that must operate as far as possible to a failure free standard. So imagine, where are they and where are we? So we have to actually move towards this culture of safety and as a high reliability organization. That should be the goal. So early adopters we have seen. And now look at your own system. Where are we with regards to our safety culture? There are different levels of safety culture. The first one, we call it as the pathological one. No systems in place at all. You talk about international patient safety goals or talk about patient safety. Nobody in that organization will be fully proficient with that. I think most of our organizations have moved away from this because at least some basic minimum standards by way of accreditation has been established, or we are going on talking about it. So therefore, I think we have moved away from stage one. Reactive culture. They are piecemeal. Systems are piecemeal, which means in your surgical side, you'll have a surgical safety checklist, you'll have some timeout procedures conducted. You probably will be doing some basic look-alike, sound-alike medications and keeping them properly. So it's more a reactive culture because here you would have had a problem and you have put something in place. That's about it. The third level is a calculative structure where any incident happens. It's a systematic approach of analyzing what has happened, doing a proper corrective preventive measure, putting systems in place, and also the concept of a risk mitigation, which means our overall risk management, which is, looking at multiple things and trying to avoid harm, is what is called as a calculative safety culture. The fourth one is a proactive culture. Problems may not have happened. You must be learning from various other systems and you try and extrapolate that to healthcare, and you're being proactive and trying to avoid problems from happening. It's a proactive culture. And the final one is a generative culture, which is where we have to lead ourselves towards. It is not a group of small individuals doing that, but a very meaningful safety culture, central and core to the mission of the organization. And that should be the aim of our organization. Now you can imagine with this picture in mind, where you stand as an organization. I think most of us are in the calculative phase, and some of us are moving towards the proactive phase. That's my own understanding. What are the characteristics of a safety culture? What are the characteristics of safety culture? Now, this is also not from healthcare. This is from the Institute of Nuclear Power Operations. They have defined safety culture, the characteristics of that are adaptable to healthcare organization. Okay, so what can we learn from them which are adaptable to our organizations? First and foremost is the leadership commitment to safety in their decisions and behavior. So if your leader hushes everything, doesn't take safety incidents care, it's a very careless approach, then there is a problem. So the foremost thing is leaders demonstrating commitment to safety. When we talk about leaders, it is not just the CEO or the owner of the hospital. It is leaders at different levels. It could be a unit level leader, a nurse manager, a CSSD manager. So the leaders at all levels demonstrating commitment to safety. Decisions that support or affect safety are systematic, rigorous, and thoroughly looked into. So it is not like ad hoc, just listening to some gossips. So you have to take decisions with data, go into that in a rigorous and systematic manner. Trust and respect permeate the organization, which means you are no longer worried to report anything. You trust your employees. You have to have that respect for other professionals. And therefore, everybody works towards this. Opportunities to learn about ways to ensure safety are sought out and implemented. So you're constantly in the lookout for opportunities for improvement. Issues potentially impacting safety are promptly identified, fully evaluated, and addressed. Now we are talking about identifying the hazards and addressing all of that. A very safety conscious work environment is maintained where personnel, staff free to raise safety concerns without any intimidation, harassment, discrimination, or fear of retaliation. So these are the characteristics of safety culture. No. So the most important thing that we talked about is the role of leadership. So the 3 elements of safety culture, this is from the Joint Commission International. These are the 3 things the leaders must aspire to establish in their organization. Fair and just culture, reporting culture, and a learning culture. We'll look into that, maybe just spend a minute on these 3 cultures. And what we have to learn here is this just culture is most important for establishing a culture of safety. What is this just culture? People are encouraged, even rewarded. I know of organizations when, it's called the good catch and the bad catch. So when there is a good catch, they are actually rewarded. They have averted a patient safety incident from happening. So people are encouraged, even rewarded for providing essential safety related information. But clear lines are drawn between human error and at risk or reckless behavior. Okay, you have to be very careful here, which is human error could happen because somebody, it was a mistake. Whereas there is something called as a reckless behavior, which despite whatever systems you put in place, some people behave in a particular manner. Okay, so they don't take things seriously. They are not worried about the other person's safety. So that's a very reckless behavior. So you have to have a clear line of distinction between a human error or a reckless behavior. So the just culture is all about reporting. You have a culture created in such a way that people are not intimidated, they report. Now the reporting culture, everybody takes responsibility to report their errors and near misses, their own or their peer, in a very open fashion. What is this learning culture? It is a willingness and the competence to draw the right conclusions from whatever has come out of the reporting, to draw the right conclusion from your safety information system, which is your incident reporting or your facility rounds or part of your other audits that you do, and the will to implement major reforms when their need is indicated. So that is what we call as a learning culture, constantly learning from our own practices and also learning from other practices. Now, whatever we do, if we don't measure the culture, we don't know where we are. We go by anecdotal statements. All right. So that cannot be accepted. In quality principles, what is measured can be managed. If you can't measure something, you cannot improve upon it. It's very straightforward. So how do you measure this abstract thing of culture of safety? Okay. So if you don't measure, there's a huge problem. So how do you measure that is the question. So it may be required by regulators in the Western world. It is actually prescribed by the regulators that they have to measure their culture of safety on a yearly basis. Now here we have to, our NABH has prescribed that in the PSQ, the newer 5th edition, JCI in its 7th edition, and I'm sure the QI standards would also be prescribing that as part of their standards. Now, how do you measure that? Well, there are many tools available. These are validated tools. So we can't just like that put up our own questionnaire and do the survey. We have to have validated tools, because unless you have that, you don't know the whether your instrument is capturing the appropriate information. The more rigorously tested tools are the SAQ, which is the Safety Attitude Questionnaire, SOPS, which is the Surveys on Patient Safety Culture, HRQ, which is what most of us use. Then you have the Manchester Patient Safety Assessment Framework. Then you have the SCORE, which is the Safety, Communication, Operational Reliability. And then you have the Engagement Survey. So the SOPS is the one that we most commonly use in our country. So while you take up the survey process, you need to plan out well in advance, prepare the tool, because you may need some customization. If you look at the HRQ tool, there are some languages, some language use, which our people may not be fully proficient with. So you may have to tweak that language a little bit. So prepare well ahead of time, conduct the survey, analyze, debrief within yourself. Then you have to inform your higher top management. You become part of a larger team to go through and analyze the data. And then you decide these are the areas of improvement. In my organization, the last year we decided we have to bring in the reporting culture. So because that was a little low, others were okay. So we are now working towards an automized tool towards reporting, an anonymous tool. So all that is in the process. Once that is done, then you improve upon it. you sustain, and the next year again you resurvey. This is a continuous process. Unless you measure regularly, you will not know the improvements you are making to your culture. So, how do you promote safe culture? I'm just putting a list of all the points that we could do to promote this safe culture. Hold everyone, including the management, accountable for following safety policies in order to promote a safe environment. Establish trust between the employees and management. We have a very large role as quality managers, patient safety professionals, people engaged in administrative roles, clinicians. All of us have a major role in establishing the trust between employees and the management. Advocate an open door policy. If there's a safety concern, anybody could walk into my room, report the concerns. Hire employees who have the eye for safety. That's again very important. Not everybody will be, it's sometimes you say safety culture also comes by birth. So you also have to have an eye for people who have details in front of them, who have an eye for safety. Take safety incidents very seriously. Do not just hush it or wash it away. Perform, and you have to do a detailed corrective preventive action and communicate the action taken to the staff in your organization. Train all your staff on risk identification, the implication of just a loose wire hanging somewhere, implication of risk and unsafe practices. Provide your staff with resources on risk management and safety measures. Engage. That's very, very important. Keep on talking to them about building the culture of safety, why safety is so important. Quote incidents to them, narrate things to them, so that they also become aware of the importance of this safety, and they will then come into the culture. Lead by example. I think this is the most important thing. We have to lead by example. So, by and large, these are the references that I have taken for making my presentation. I just want to mention this and close my talk. This is what I have written for people to be engaged in this culture of safety. So all we need to remember when you get into your hospital, the most important thing to remember is we are doing work for saving others. The patient or the relatives trust us and they have come to us. The patient, that one patient, it's probably 100 patients for you. But that person, that single person, is probably the sole breadwinner of a family. He's probably the father of a very small kid. He's the son of an old father or a husband of a very young lady. And he's now your responsibility to treat him well, send him safe to his loved ones. Imagine, it's your responsibility. So you have to imagine your own there, which means your own brother, sister, your mother, or your daughter there. Take care of him like your brother. Then the culture of safety will automatically come in whatever you do. And when one person starts, the spark will spread and the entire organization will be tuned to the culture of safety. Best wishes to all of you. And I truly appreciate the work done by Society for Emergency Medicine in India for the wonderful job they are doing to promote the culture of safety in this country. Thank you so much for this opportunity given to me.
Ma'am, thank you so much for joining us today. And it's always a pleasure to listen to you. And for just on an interesting note, what many of them may not know is actually Sridevi was born at Dr. Mehta Hospitals, 1963.
Oh, really?
So, yes, so we did manage to provide safe maternity care for her mother, only to lose her to medical negligence to some hospital in US. Very unfortunate. Maybe she should have picked us for surgery as well. But with that being said, I think you had a very striking end note. And I think that I keep repeating to many of the young colleagues whom I speak to as well, right? So whenever you take a decision on any of your patients, just substitute that patient with your own family member, right? Think about them as your own son, daughter, father, mother, and think for a second whether you will do that procedure without washing hands or whether you will continue to attempt for multiple procedures in case if you're not successful, and so that like you'll get to the right answer always. So very striking end message, ma'am, and thank you for joining us today. I think in the chat, I'm not seeing any questions, but perhaps Dr. Srinath might have something. And I think you got a few questions coming in. Dr. Srinath, do you want to go first?
It's always a pleasure to listen to you, ma'am. That's all I could say. The question is about the safety culture. Always people think that what we are doing is right and what we are doing is wrong. And you have already mentioned it in a simple way how to look into and the origin of international patient safety goals. So to the young listeners who are here, can you just inform them or reiterate them what it is important about international patient safety goals?
Yeah. So the international patient safety goals have been formulated considering the major areas of concern in healthcare industry. Though it is the Joint Commission International that has formulated it, it is all based on the data that they have collected over the years from various hospitals that they have accredited. So they have noticed that poor communication has contributed to errors, and AHRQ actually publishes the top 10 medical errors across the globe every year. So if you look at it, the goal one, they talk about identifying the right patient. So, it is so important. If you don't identify the right patient, then you could end up with a lot of errors, wrong patients being operated, wrong procedures being performed. So not in any particular order, the IPSD talks about high-risk medication management. It talks about identifying the right patients. It talks about the surgical safety, and also the effective communication. Improve safety of high alert medications is the third one. Ensuring the correct site and the right patient to operate, that is the goal 4. And reduce risk related to healthcare associated infections and reducing the risk of patient harms from fall. So these are the 6 goals that are put in place, because these are the major harms that happen in hospitals. Okay, but this is just a guiding document. This is not all about, this is just to create that awareness that these are the top risk. So please focus on them. That is why it is said as international patient safety goals. Now, we also have our own national patient safety goals, far too many in number. Many of us don't even know, but at least here we know that these 6 risks, we have to focus on them and make sure that our patients are safe. Yeah, Dr. Shri.
Thank you, ma'am. Thank you very much for putting it at a nutshell, so that all those who are watching here, and also this program is live on YouTube, and the residents who could not be there for today's program, they can go back and see on the YouTube also, and the link has been shared. So, ma'am, you can also share to your colleagues who wants to see the program. What do you say?
Thank you, and ma'am, thank you so much. I think in the want of time, we may have to move to the next presentation, but thank you so much for joining with us today. It's always a pleasure to listen to you.
Thank you. Thank you.
You're most welcome to continue on, ma'am, and to stay with us.
My apologies for the, delays. Thank you so much.
No, that's all. Thanks a lot. Thank you so much. And I think we'll quickly move on to the last talk for today, which is by Dr. Srinath. He's going to be taking through on some of those guidelines which are available in India. It's been a common question from many of our colleagues asking, is there a standardized document available from SEMI in some of those protocols or in some of those policies, some of those standardized documentations, etc.? Yes, there is, right? And Dr. Srinath is going to take us through some of that in the next 10-15 minutes. And please stay on after that, because we've got a very interesting Kahoot quiz coming on after that. Dr. Srinath, over to you, please.
Thank you very much, Dr. Saruna. And again, I started with the quality and ending with the quality of today's program. So it is always a pleasure to speak to you all and looking into the perspective. So when we were thinking about the quantity, we started the process of looking into forming the emergency physicians across the country. And the many corporate hospitals, many private medical colleges, many government medical colleges, everybody started writing to us saying that, yes, we need emergency physicians. So that was the time when we in the SEMI board, me, Sarvana, Imran, everybody sat together and started looking into how to improvise the number of students into the country. And then we achieved it accordingly. Then in 2015-16, when again it came back like, okay, now we are achieving the number of students, because there is an MD program, there is a DNB program, there is an MRChem program, there is a 3-year MEM, CCTMs, many programs are there in the country. But how do we monitor the quality of this, the patients who come into the emergency department? So that's when it came into an idea. And also I should thank the AHPI, that the Association of Healthcare Providers of India, and through that association, Dr. Sarvana, who is very well associated with them, they were speaking to ISRO, and ISRO we all know that the zero effect should be there. There should not be any kind of a negative when they're launching any kind of a space or a space equipment. So we spoke to them. There was multiple meetings with them. We looked into the best practices, what we are doing. And then it all started like this in 2017, where we started writing about the quality into the accreditation. And then we took the best practices of the space technology, that is quality accreditation enabled through space technology. That is how it came into. And the nomenclature also, it took almost 2 to 3 days, wherein it was brainstormed and said that, okay, this is Health Quest, which is important for the emergency department. And you can see the stalwarts from ISRO, from the quality, from the AHPI, from CAHO, from NABH, everybody came onto one table and said that, yes, this is an important start, because we all know that how many mistakes will happen in the emergency department, giving the old gesture that in worldwide, they were seeing that there is about 12 to 13% of mistakes which happen in the emergency department across the world. So that is the reason why we from the country of India, we wanted to be the first to be associated with the space. And Indian Space Research Organization came forward and said that, yes, we will be cooperating with you and coming up with the guidelines. So that is how it became. And next, we don't want to keep it very, very complicated. We want to make it a simple document. It should be relevant to our emergency departments, and it should be easy to be implementation. Only when these three are there, then only our people will also be ready to do so. And resources came from all the knowledge from our partners, whatever I have mentioned. And after all these things, we should also know that whether our outcome is measurable or not. So these are the 4 objectives which we kept in our mind. And then we came out with the ISRO design, which is the design which they follow is always quality of design, quality of conformance, quality of performance. So they put these 3 things into combined, and then only they launch anything which is required. And if you see the SEMI logo also, it also has the 3 quarters in it: academics, service, and research. So in the same way, we were also very, very perturbed, and we were very impressed to see that the ISRO is also having this 3 triangles, which is based into and merging to look into the best practices to be coming out. So then came into an idea, and then we saw how to design it. So the simplest way to design it, we all know that we have 3 parts in the emergency department: looking into the emergency medical services, triage, and then the emergency department. So not much will be looked into the emergency medical services. So what is important is, here we know that we need to design our emergency department once they get into the emergency services. So what is important is look into the triage area, from where the emergency ambulance comes in, and then where the patients will be waiting. And once they come into the emergency, how the triage area should be there, and where the patients have to be taken into. So once they enter, the triaging is done. They are taken into priority 1, 2, 3, 4, according to the needs of the patient. And then accordingly, whether the patient has to be resuscitated or kept in the emergency, treated and shifted to the ward or to the OT, or if somebody wants to go against medical services, they also are being sent out. Or if the patient coming into P4 area where they don't require an emergency, then they are sent into the OPD or fast track consultation room. So this everything put together was being done, and then the exit plan was being made into. And most important thing is, wherever the emergency department is there, it's another 2 departments which has to be there. The billing process. The patient should not be allowed to run around for a simple reason that they have to pay a bill or they have to register themselves. And also the pharmacy things which is required. So apart from this, what is required in your design process? The design process also require your manpower, looking into clinical healthcare providers, that is your doctors, nurses, paramedics. Apart from that, your billing, housekeeping, and other support system staff are also be looked into as a design module, which is the manpower. And then pick out who is smart enough, like a quality champion, and then design accordingly what I mentioned, priority 1, 2, 3, 4, and make a correct flow where the patient has to come in and how the patient has to go out. Lastly, your day-to-day equipments, which has to be kept, which has to be monitored every day in and day out. So that is how we have been designed and which has been followed. And it's very, very, you can see, which can be measured, triaging, skill and time. Say, so keep a nurse or a doctor there. So they'll take the patient in once they receive the patient. So that means that the 0 second starts there. What is the time to be seen by a nurse, then to a doctor assessment, then for a management protocol, and then becomes a disease specific going into ER to ICU or to the operation theater or to the ward, depending upon the criteria what you have mentioned. Then conformance. So once you have done, it's important that every protocol has been integrated. Let it be your code blue running sheets, or let it be a CPR, let it be a stroke, let it be a myocardial infarction, let it be a poison patient, like this. Every initial protocol should be framed, and that is how the Health Quest module has become one of the most successful module, I can say. And when the patient has to be transferred out of the emergency department, what is your integral quality? You have to integrate the quality from the main quality department to the emergency department. And then lastly, your communication, both with your patient as well as with your colleagues, and also to the patients who have been referred upon. Lastly, satisfaction. The patient who comes in should leave the emergency with a satisfaction. So these are the conformance, which is very, very important. Some of the few things you can directly download from the net about the Health Quest manual, you'll get it. And then what is there important is how the patient has to be initially, the doctor's initial assessment should be planned upon. How the patient has come in, whether he's come in an ambulance or walk in, or whether he's on oxygen, ventilator support, everything. And then once the patient comes in, look into the ABCD, that is your resuscitation, and then prioritize the patient and resuscitate the patient. So that is another important thing. Now, you've done your both the things right. Now you have to look into the performance. If you don't measure your outcome by looking into your performance, you'll not be complete. So what are the main things which you can do as an audit? By Dr. Mabel has already explained to you in detail about the audits. But as part of the Health Quest manual, I would like to say these are the things which you're looking into. Doctor triage time, doctor time, the thrombolysis, let it be myocardial infarction, or you're taking the patient for PTCA, or patient with stroke, or patient with sepsis patient, given your antibiotics time, then pain score assessment. What is the investigation? You have sent at 0 minutes. What is the patient investigation which it has come back? Nurse patient ratio, patient satisfaction level, time taken for discharge. Because everything, you say that you already informed that, okay, I'm going to discharge the patient. Then somebody has to monitor how long it takes a place for a discharge. Mortality, every month mortality meetings, CPR committee meetings. And then what is your process parameters? What is your length of stay? Maybe some hospitals have 3 hours, 4 hours, 5 hours, and depending upon your triage time. Priority 1 should be shifted out at the earliest, because if you clog the patient inside the emergency, you're going to waste the time. So do a proper, whenever you feel that the patient is waiting or lasting his time in the emergency department itself, do a proper RCA. That's how you can improvise, keep on improvising, and then only you can give the best care for the patient. And finally, in August 2017, the module came out and it was launched in a big way, and it has been followed. Then did we stay quiet like that? No, we went on, stayed with the ISRO, and made some of the hospitals which came forward as a pre-intervention and post-intervention phase, and looked into and formed a steering committee with all these people with the document. And then we went in. And thanks for the Narayana Hrudayalaya team, which developed this REDCap, which is nothing but the Research Electronic Data Capture CAP, which was a simple app which helped us to collect all the data. And all these hospitals, we looked into how the pre-intervention phase, and then we also looked into how the flow of activities, like patient is coming into ER, tag the patient. Every hospital will tag the patient. So application, then triaging, nurse assessment, doctor assessment, protocols, investigation reviews, pain assessment, and lastly the disposition. So this is how the tag was been put in, and the app was been very, very helpful for us to note how the patients are going in for. And another thanks to Dr. Sarvana, who led with the first team which came out with a paper which mentioned how the health quest document was helpful, and it was being published also, and it was having a good reviews. So lastly, thank you all for listening to this whole online workshop that is on quality in emergency department. Without quality, you can never have a patient good care. And to have the best care, you should always know the quality parameters which you are keeping in your emergency department. So thank you for Society for Emergency Medicine India. Thank you for the management of Yashoda Hospitals. A special thanks to Dr. Pavan, who has always been helpful in helping me to organize such academic events, and also Dr. Lingay sir, who is the Director of Medical Services, and the whole board of the semi-board, starting from our President, Dr. Venkatesh, Secretary, Dr. Sarvana Kumar, Joint Secretary, Dr. Sai Surinder, Treasurer, Dr. Saujanya, and all the vice presidents of the society, to keeping a good faith in me to lead always in the academics for the society. Over to you, Sarvana.
Thank you so much, Dr. Srinath. And for those who are trying to set up processes in your department, or those who are new to leadership in the department, or those who have just taken over a unit or a department, please refer to these guidelines. These are available as a free source. You can just Google it as Health Quest ER. You might perhaps get it from the SEMI website, the HP website, the CAHO website. Kindly download it and go through it once, and you don't have to reinvent all of your processes and protocols. Many of your standard ED processes are already well defined. Please feel free to adapt them. Dr. Sheena, thank you very much for taking us through this. And I guess we have moved to the very important part of today's presentation, which is the Kahoot quiz, right? And I think there is a notification to join that, and I think Naveen can take over from now on. Naveen, over to you, please.
Yeah, so if you check, you will have received one notification to join the Kahoot quiz. So if you're on the PC, you should be able to, yeah, the pin is displayed. So that is 412-4030. Or if you are in a mobile, you can go to www.kahoot.it and enter the game pin. Okay, people are joining in. Once we reach eight members are in, 9. So we have about 30 participants in the chat box. So if we go to 20, we'll start. It's easier to join from the PC. So you have about 30 questions. Each question will be given about 20 seconds, depending on if you are able to answer faster than that, it will move to the next question. Otherwise, it will wait till 20 seconds. Okay, we will start then. We have 13 members who have joined here. The first question. What is activated upon arrival of the patient? Staff should be trained to respond promptly to the alerts. Time up. Yeah, one person answered incorrectly, but you should be having an alert mechanism. Next. This is the scoring. After each question, you get to see how much you are scoring. The quality of water should be checked. Yeah, once in 3 months. That's there. And okay, so the sooner you answer, the higher your points will be. So if those who are answering immediately, they will get more points. Effectiveness of mass casualty incident plan is tested at least dash in a year. Okay, the correct answer is twice a year. Next question. There's a document process for calculation of manpower needs for each shift in emergency based on what? Yes, the patient volume. Minimum training requirements for all nursing staff in the EDCs. ACLS. Question 6. Emergency doctors, at least the head of the ED, should have training in. ED ultrasound guide. Question 7. The facility has dash which reflects support for the ED team as a priority. This is a little tricky. Yeah, the correct answer is gender equity policy. All the verbal or telephonic orders must follow dash policy. That's number 4. That's read back policy. So whatever orders you receive, you have to read back. That's what we call it as closed loop communication in ACLS. If patient care notes are documented by the junior clinician or nurse, the same must be verified and countersigned by a higher level physician or nurse in charge. Next. What's to be used in the patient discharge summary? No medical abbreviation. You need not use national language. Question 11. The documented quality improvement program is developed, implemented, and maintained by. A multidisciplinary committee. The patient safety program is reviewed and updated at least that's once in 12 months. Question 13. If a specialty is unavailable at your care, a patient can be referred to other facility. However, referral out to be done only after needed life-saving management has been done. Ambulances are manned by dash during critical transfers. Trained paramedics or nurses. Fifteen, all medical equipment's regular preventive maintenance is up to date and is checked using what? using a checklist monthly, weekly, daily, once in 3 months. That's daily. Dash are trained in attending ambulance EMS calls for screening, prioritizing, and better dispatch. All ER staff, doctors. Documented policy and procedure for use of narcotics and psychotropic substances exists in consonance with Dash. Local and national regulations. The facility implements hand hygiene practices as prescribed by WHO. A dash is unplanned event that did not result in injury, illness, or damage, but that had the potential to do so. An EMS event. A plan or set of steps to be followed in a study, an investigation, or an intervention. That's a protocol. A dash identification number is generated at the end of registrations. That's a unique patient ID. In case of death, the summary of the case also includes the cause of death must be included. Ambulance emergency medications are checked. Daily and prior to a dispatch using a checklist. Informed consent is taken by whom, where applicable. It should be done by the personnel performing the procedure. The EDs across the country get abused by other departments for not taking consent, but they are supposed to take it. Medication orders are written in a dash in the medical records. Uniform location so that it's easier to look up. Prepared medication is dash prior to the preparation of second drug. Labeled prior to the preparation of second drug so that it doesn't get mixed up. How staff joining the ED undergo what and also occurs when job responsibilities change or new equipment is introduced. Job specific training. The medical record provides a complete and dash account of patient care. That's chronological order. There must be a system in place to identify patients with communicable disease. At the triage level itself. Last question. An unexpected event happening at the hospital which involves death or serious physical damage is that's a sentinel event. And let's look at the leaderboard. Number 3, Hiral Panchal. Number 2, Parthipan. Number 1, AN. I hope that's not Dr. Venkatesh. Okay, I'm stopping this. Dr. Sarvana.
Thank you, Naveen. And first, congrats for sticking to time. It's exactly 6 p.m. and I think we have come to the close of the program. And on behalf of Society for Emergency Medicine India, and thanks to the host, especially the Yashoda Hospital team for running a fantastic program for the last 3 hours. I think in the want of time, we may not be able to take more questions, but I think most of you have got our contacts directly. You're most welcome to post or ask us any questions. But before we all sign off, maybe a quick group photo would be useful, and may I kindly request everybody to turn on your videos if possible, and maybe Manikam can do the honors of clicking a group picture of all of us together. And thank you all for joining today. Yes, Manikam, you can give 5 more seconds and then you can click the group picture. Monica, are you taking one?
Yes, sir. I have taken.
Okay. You want us to smile? You want to do one more? Thank you so much, Monica. And I think with that, thank you all so much. I wish you all a very happy weekend. Right? Have a good evening, all of you. Bye-bye.
Thank you, sir.
Good evening. Thank you.